to the stage and as a tradition from this side. Prof.
Can I speak? Okay. Good morning, everyone. And let's start today's session. The first is my presentation about new development in the study of the brain. Okay, first, I'd like to introduce human resources. Human development is fascinating and important theme of science, and a large number of human embryos have greatly contributed in the understanding of the human biology. Here means we have to use laser pointer here. Okay. There are three major human biological collection resources, and the Carnegie is the oldest one. It's stored in Human Development Anatomy Center in Washington, D.C. The second is the Breshmet collection, started in the 1950s at the Göttingen University in Germany. And the Kyoto collection is a relatively new collection of human embryos. And since 1961, a large number of human conceptuses have been collected in Kyoto University. And most of specimens are obtained by artificial abortion for socioeconomic reasons and the maternal protection law of Japan. And the embryo collection now comprises of 44,000 specimens, and part of them are undamaged, very preserved embryos. And the characteristics of the collection is very interesting. And most of specimens were obtained by artificial abortion. And the most of the embryos have been derived from healthy women with normal course of pregnancy in the first trimester. And attending obstetricians did not examine the aborted embryos. So it means the Kyoto collection can be considered to be representative of the total uterine population in Japan. And that is the ratio of normal abnormal in utero at each destination weeks can be elucidated using this collection. And the change of the ratio can be observed in the longitudinal study. And the variable samples for epidemiological analysis as well as morphological research. And here is the summary of the development by 9th week. Major developmental events occur at the finish. And here we can see okay, this is a movie from the, this first 6 7 stages fantasy, but the, at the, here, this is fantasy. CZ, but the stage 6, 9, and around this stage, we use the MRI data and go to the surface data, go to the 3D CG. So it is not fantasy yet. Based on the MRI data. Okay, developmental stages in human embryos is called Carnegie stages, defined using the Carnegie question. And it is diagnosed from the morphological findings, not by day after fertilization. Carnegie stages consist of 23 stages. The stage 1 is first day after fertilization. And the stage 23, almost 50 days after fertilization in the middle of the 9th week. So that's the this age. So in my presentation, we use the Carnegie stage 30 to 23 and after fetus stages used for the embryo and the fetus imaging. Okay, for live embryo, in the obstetrician, ultrasound or MRI or CT we can you can use, and that's our sample is dead embryo, so we use a lot of what can I say, very stressful imaging for brain X-ray, CT, X-ray, contrast X-ray, and the MRI. If you take MRI, very short time 20 seconds or 30 seconds for scan. But here, our MRI image, the embryo specimen soaked into the water and take MRI for 1 day or 2 days, very long scan to get a fine image. Okay, we use several imaging modalities. The MRI is the microscopic MRI is set for embryos, specialized for embryos, and experimental 7 Tesla MRI is the probably most of people, most of the researchers use for live imaging or primates or some experimental animals, but we use for a very tiny embryo for 1 day or 2 days. And the clinical 3 Tesla MRI is set on the hospital. At daytime, the clinical 3T used for patients, and the nighttime, the people allow us to use for experiment. And X-ray CT, absorption contrast CT is the usual conventional one, and the phase contrast is our special X-ray CT. And first, I introduce you about the embryo imaging using MRI. And we have several MRI devices for a tiny embryo. First, we use the 2.34 Tesla magnet in Tsukuba University in Japan. It is used 20 years ago, very old one, but we have a lot of fine images. Next, this 7 Tesla NIH magnet. I went to NIH almost 15 years ago and brought embryo and took MRI images. And now we use the 9.4 magnet in Tsukuba University. Tsukuba people make devices, so technology people. And sample for scan, we have to prepare the sample and the soaking contrast medium or only formalin solution or pure water. And the here we show 73 MRI images. Okay, sorry, it works. Okay, the movie is not work. Oh, sorry, it work. Okay. This is the MR images at Carnegie State 13, and the resolution is 35 micron per pixel. And average mean, the devices took MRI pictures 70 times, and the average the data to improve the noise and signal. And scan time is almost half day, 12 hours. And next is the coming stage 18. Sorry, the movie is not work here and here. Okay. This is a resolution 50 micron per pixel, and the average is at 6, and almost 1 day, 19 hours to, it takes 19 hours to take these fine images. And this is the largest embryo, candidate stage 23. And the movie work here, or how about this movie? Okay. And the resolution is 55 microns, very tiny, fine resolution, I think. And it takes 25 hours more than 1 day. Okay, here's a figure, photo and 3D. The left row is the photo. And this is the 3D reconstruction, surface reconstruction, and sagittal plane images. We can get fine images, especially in later stages. And here is this accounting state 22, almost clinical images for the adult or something. But this is embryo, very small 2 centimeter embryo. Yeah, this is summary of the IMR microscopy for human embryo. And in later stages of human sample, after accounting stage 18 or 19 or something, the resolution enough for the analysis. In early stages, it's not good, I think. So 77 MRI, almost 50 cases have images. Only image, not analyzed. And 2.34 took by MR microscopy, and more than 1,000 cases have been imaged and made into database in 20 years ago. And the resolution is no better than 77 MRI, but they're analyzed still now. The next, I want to introduce recent imaging using phase contrast X-ray, CT, and MRI. And this is a phase contrast X-ray, CT. What is a phase contrast? So I want to introduce absorption images and phase contrast imaging. And absorption contrast images is a conventional X-ray imaging. Projection image is conventional X-ray. This is a test, and CT is probably you usually use one. So X-rays used in daily clinical practice and advantageous for imaging a wide range of biological structures from bone to air. And phase contrast imaging this year advantages for soft tissue. So and once at a time, more sensitive than absorption images. So what is phase contrast? This is something physics. I don't know you like physics or not. And the X-rays, electromagnetic waves having very short wavelengths and are mainly characterized their amplitude and phase. When they pass through samples, their amplitude is decreased and the phase is shifted. In the hard X-ray region, the cross-section of phase shift and light elements is about 1,000 times larger than that absorption. It means the separate X-ray waves at the crystal and let one pass through the sample like this. And the one that passes through has phase shift. And when it is superimposed again, the interference fringes are generated. The leftmost, we use laser pointer. This interferogram means is a photograph of the interference fringes. After the image processing, we can get phase map or phase map here. Phase map almost equivalent to the projection image in X-ray. So for the phase map image, we can reconstruct CT images, and the device is here and here and here you can see every embryos. This machine is in almost in also in the Tsukuba City high energy accelerator research organization, and this is all this institute, and here is a building of the photon factory, and in this near the ring you can access that devices. So we use very large devices to take very tiny embryos. And here is a phase contrast CT. This is a 13.5 mouse embryo. And here, and this left is a 3D reconstruction and rotation. And here's the carbon stage 13 to 17 human embryos, 13, 14, 15, 16, 17. And this is a comparison between the phase contact CT and MR. Here is a right lane is a MR, and the left is a CT. And it's very tiny. For example, here is a Lasky's pouch, the primordial of the pituitary gland, and in the MR it is not fine, but in physical capacity it's fine. Or as a this is a spine or somite, it's very clear, and this is a little bit dull. Next, clinical 3 MRI 3 Tesla, using the latest machine in the Kyoto University, and we try to tractography using full body scan of fetus, not exactly to brain. And this is a tips of imaging, so I would like to skip. And here is the result, DWI and phase in the DTI color map, and we can get a very tiny signal and reconstruct tractography. And this is yeah, I know if you extract the brain very fine image, you can get the images. But see, if you experience dead embryo or this bone, this dead embryo, the patient patients don't like to extract brain. So after the getting dead fetus, okay, sorry, not the embryo, dead fetus, probably patients don't want to dissection or something. So if you in the case, you can get the MRI image or tracked over here. A lot of research you can do. And using clinical MRI, you can get 0.2 millimeter isotopic voxel level and very fine images. And now we try to 0.1 millimeter isotopic imaging using clinical devices. And recent advances in micrography. A recent paper has been published on embryo imaging. This is embryo imaging, and it has achieved a resolution 10 micrometers using MRI. We intend to take a large number of specimens and create digital apparatus by using these devices. This is a short summary. The MRI images are fine, especially in the largest, later stages of human embryo. Fine contrast X-ray CT novel modality, and the resolution of the MRI is still advanced. Okay, I love Indian food, and I go to Indian restaurant in Japan to at least once a week. And I asked the owner of my favorite restaurant in Japan. He's from North India. At what age, when children can be given spices? And he said, not until the child is 1 year old. So now my first trip, my boy is 1 year old, 1 year and 2 months, and he now first trying to Indian food here. And now he has a gifted education about Indian cuisine. And he loves naan. Here is a naan, and the bit of the naan he can hold his hands. And he loves naan and very happy to eat it. The spices have not been to give it yet. Okay. Research findings using imaging. So our brain-related research in recent 2 years, 50 articles have been published on fetal brain. Since we don't have time to introduce all of them, I will pick out the most characteristic one and introduce them here. The first is the almost 10 years ago. This first paper is covered in yesterday's speech, so I'd like to skip it about correct practice. Next is 2016 Shiraisi brain depth one. This paper is interesting and important. Probably Dr. Pu read this paper recently, and here is the embryo brain development. The upper range is surface reconstruction. The lower is ventricle, and here, and surface color mapping external view of whole brain. That red area indicates thicker neural tissue. So first, brains form neural to very thin neural tissue, but see during development, the neural tissue is thickened, but not even. The part of the neural tissue is very thicker, and this figure is the only thick portion extracted. So this is a Carnegie stage 70, 20, and 23, and it means the embryo. And in all stages, area thickening coincide is the basal ganglia and thalamus and pyramidal tract. So in embryonic stage, those basal ganglia, thalamus, and pyramidal tract starts development. And later stages, this cerebellum is growing. Next is a Yamaguchi paper 2018. And primary, secondary brain vesicles are segmented and reconstructed in 3 dimensions. This one is also introduced in yesterday's lecture. Here is a very characteristic paper. This paper attempts to mathematically represent the morphological changes in the brain. The authors are mostly from the informatics and mathematics people. So since the paper has been published, I think the attempt to mathematical representation was successful. But please don't ask me questions about this content. I know mathematics people, so I don't understand all the contents. And next and the final theme is the recent challenges. Face predicts brain is very, this is very famous paper in 1964, yes. Abnormalities in the brain can be inferred from facial appearance. For example, this is holoprosencephaly. This is embryonic for holoprosencephaly, and this the features face is very different from each HP cases. And the severity of HP correlates with the degree of facial abnormality. It's true. And the lower 3 is almost cyclopia. Also, all embryonic HP is very severe. Okay, quantitative analysis of shape. At first, setting landmarks, you set a point on the anatomical structure. And here, conventional method, we quantity, length, and angle. So after that, shape becomes just the only number. So shape cannot be restored, it's gone. And now we use geometric morphometrics, use coordinate values x, y, z as here, and each point has the coordinates x, and y, and z. So relative positional relationship of each coordinate is maintained, so enables to restore the shape. So calculation uses matrix analysis. For example, this is the laser septum shape change. An important structure of mid-facial skeletal growth in pairs growth causes, for example, the Binder phenotype or something. This is a two-dimensional quantitative analysis of the morphological changes of the laser septum and performed in the early period using GM. And here is the movie of the shape change. The 8-point was set on the nasal septum. This position of the point changes around the development. And the result is the nasal septum was growing with anterior posterior deformation. And now we study the correlation analysis of shape change. This is unpublished on submission, the newest paper. The analysis of the relationship between midface formation and the pituitary Cerathuria tussica shape changes. And we don't have enough time, so we omit in detail. And the correlation analysis indicated a certain relationship. And for example, in Down syndrome, abnormal morphology of sera and hypoplasia of the midface can be seen. So this is probably one achievement that provides some proof of association with pathology of this disease, I think. Here's a lab made by an acknowledgement is Kyoto University and Tsukuba University and NIH and the University of Pittsburgh. Thank you for your attention.
Thank you, Prof. Really mind-boggling images of the embryo we have seen. Now we will move on to the other lecture, that is early diagnosis of NTD by Dr. Karina. Right?
Hello, good morning. I hope you see my slides in just a moment. Yes? Can I only have a okay that it's fine that you are seeing the slides, please? Okay. So good morning again. And I'm very happy to be here again with you guys and for a new day of Congress after this brilliant lecture. It's very, very early here in Israel, and again, sad to be away from you, but happy that we can be present from far away. Indeed, it's very unfortunate that a war and the terrorist group is able to take us apart, but here we are, and we are going to discuss a very interesting topic about the early diagnosis of neural tube defect. And I will, like yesterday, I will keep my efforts in order to make diagnosis. We are going to speak a little bit about screening, but most of our efforts will be focused on the directed diagnosis of these interesting entities. So the neural tube defects, they may be divided grossly into open and closed defects, and also we can focus our attention in the spot of the defect that may affect the spine, the calvaria, and also combine both aspects in specific cases that have more severe impairment. So again, we know that from the 80s already, we have some very important screening strategies that come from alpha-fetoprotein, and then have enhanced significantly also with the amelioration of the technologies and the imaging capabilities. But we are going again focus to how can we directly diagnose these defects. And Here I show you our transvaginal probe like as a weapon, as a good weapon that should be indeed our big tool for the early diagnosis, not only of neurotube defect, but as well as other abnormalities of the central nervous system, as well of the 3D technology, especially the multiplanar imaging. So in my experience, the multiplanar image is a very important tool that will help us also overcome different planes that we cannot achieve, and also will help us navigate through different planes, correct, obtain the exact midline. And this is a very important tool for the early diagnosis and also to avoid misdiagnosis of entities. We're going to start with the exencephaly and encephaly sequencing that we know that starts with a dysgraphia and a failure of closure of the rostral neural groove. And then first event to happen will be the acrania with the exposure of this normal brain to amniotic fluid, and then the destruction of the brain tissue exposed to the amniotic fluid. And this is a nice case, weak fetus, in which the technician calls me because she sees that the heart is pumping outside the body of the embryo. But she also says to me, "Doctor, my problem is that I don't know where is the head and where is the ramp, and I can barely see the limbs. And here we see the ectopia cordis very, very clearly. We see a very big yolk sac as well, which is also an ominous sign, but we see no signs of cranial vesicles, of brain vesicles. And always it's very important for us to put a normal comparison map in order to check how abnormal are we really staying in this specific point of time. And here we see that we see no signs of brain division at all, as expected for this gestational age. And then we understand that the calvaria was not developed, and this brain tissue is exposed and already starting to deteriorate. A little later on, and this is an opportunity to say that for this lecture, as Gustavo stated and showed the very nice picture of our team before, so for our lecture, I am using a collection of the last year and a half cases of our unit. Many of these cases that will be presented and also were taken from our dear team. So this is a work made by many, many hands. This is a little later on, 9 weeks and 3 days. Again, what we call the Mickey Mouse sign and the exposure of the both cerebral hemispheres in the amniotic fluid. Many times, as you see here, the amniotic fluid will be more echogenic, and it can be even the first clue that we have exposure of the brain tissue. And the lack of any anatomical hallmark, this is a little later, 10 weeks, will be also the other clue for the final diagnosis. Here we see a loop of bowel still inside the cord. In this gestational age, it could be a physiological hernia, so I wouldn't call it an associated defect, but for sure takes our attention in the constellation of an open neurotube defect. This is a little bit different because if we check on the fetal head, it is 12 weeks, this fetus came for nuchotranslucency, we see parts of the calvaria that were ossified. We see parts of the interhemispheric fissure. And when we check in the sagittal view, we see that part of this brain is exposure. And so, like, the defect of the calvaria is not complete, but it's partial. What we call merocrania in some countries, it has legal significance for the possibility of termination because we don't have the complete absence of the calvaria. The merocrania may have different presentations, and sometimes may look like a cephalocele here covered by skin, and in most cases not covered by skin, and then appears in the news like the baby that has survived. And indeed, it has many medical legal issues, and it's an entity that it's rare but should be known by you, especially if it's important for your local law. But some pitfalls, I will stop to show some pitfalls in different stations of this lecture. This is a case at 11 weeks and 3 days. This is twin pregnancy, and here we see a bichorionic pregnancy, and one of the fetuses indeed has this brain tissue exposed. And one differential diagnosis that we should always remember as a mechanism of disease is amniotic band. So we need to choose, and this patient had a bleeding, and we always need to check for the presence of amniotic band that can lead to the defect of closure of the narrow tube. And I really believe that we shouldn't make this diagnosis later on. Whenever we have the opportunity, we need to combine checking for the closure of the fetal calvaria in the first trimester assessment. Here in Israel, we don't need to do that. We have to do the CRL and the leukotranslucency, but I think we have the capabilities to do this diagnosis, and it's a pity that she needs to wait until the anomaly scan to be diagnosed. Speaking about cephalocele, this is a very interesting abnormality, especially because it can be associated to virtually all kinds of brain malformation. The spot of the defect will really depend also on ethnicity. In South Asians, we know that anterior is more common, and Caucasians, we know that the occipital would be more common. 80% of the cases will be covered by skin, different from the myelomeningocele, and it will depend on the content inside the cell. If we have only meninges, if we have neural tissue, if we have only a CSF, then we will give different names, including atretic cephalocele, that we don't have a big defect. Is like a form fused of cephalocele, and many times we have a small venous sinus that comes from the brain inside outside. And also we can have the glioceles that will be more difficult to be diagnosed. So cephalocele itself may have all shapes and size, may be located in every place in the calvaria, and may have different types of contents, as you can see in these illustrations. So although the big ones are very frightening, but I personally fear the most the small ones that can be missed and are many times related to syndromes. This is a 12-week fetus with a low occipital defect, and here we still don't see neural tissue protruding through the cephalocele. This is a little later, and we see here that the fetal profile is already affected. Here we have, again, a posterior occipital cephalocele with herniation already of the meninges and the content of the posterior fossa. And here's an interesting case at 16 weeks. The fetus appeared with a ventriculomegaly. At 16 weeks, it doesn't really bother the number, but we see the dangling cord plexus here. but the walls of the lateral ventricle are already quite irregular. And this is very, very abnormal for 16 weeks. We see a thin parenchyma and little echogenic. And if we check the cephalocele, is very, very low in the base of the cranium. So it's a difficult defect to be diagnosed. And here we don't see protrusion of brain tissue. So this is not the reason of the ventriculomegaly. So it could be it is an associated finding. We see the malformation of cortical development that affects the parenchyma all over, and also the lateral ventricle walls. We see abnormal vermis, abnormal brainstem, abnormal beginning of the corpus callosum, and cystic kidneys. Okay, so the constellation is indeed very suggestive of an autosomal recessive disease, maybe a ciliopathy. We don't have a molar tooth sign here, and this is not a part of Joubert syndrome. And we don't have yet, this is a recent case, we don't have yet the genetics of this case, but it for sure syndromatic. So it's more than 60% associated to major anomalies. We have all types of genetic abnormalities associated to cephaloceles, but indeed the group of the ciliopathies should be taken into consideration because they will affect the closure of the neural tube together with the brain anatomy many times, kidneys, eyes, liver, and they are multi-system disease with a high risk of recurrence. We may have also the cobblestone malformations in a differential diagnosis as well. So a good candidate for our case from before. This is another very interesting case. This is a recurrent Dandy-Walker malformation. And here I can say at 16 weeks, different from most cases of open fourth ventricle, that we really have the Dandy-Walker malformation. Okay, here we see the brainstem, we see the tectum, we see this very abnormal vermis with no hallmarks and the elevated tentorium at the level of the midbrain and the pons. So this is indeed a Dandy-Walker malformation. The father has Dandy-Walker, and this is like 2 weeks ago. The father has the Walker. He had 4 shunts. They had a previous pregnancy with a Dandy-Walker that was interrupted. They did exon 3 and CMA, which were normal in the previous pregnancy, and then they came back now with these findings. But Gustavo teaches a very, very interesting lesson that, and I cannot hear you guys, but do you know what is the most difficult malformation to be diagnosed? And whenever we see a case like this, the most difficult malformation to be diagnosed is the second one, because our eyes are so focused here, they won't see the malformation here. And here we have a very, very small cyst in the calvaria. Okay, and whenever we do the Doppler and we see a false sinus, and we see the vessel going through the defect in the calvaria. So they are going to whole genome and other investigations, but this is an interesting case. And here we remember the association of the brain abnormalities and cephalocele. Here is very, very early, 8 weeks, with enlarged and cystic kidneys in Meckel-Gruber syndrome, which is the earliest manifestation of the ciliopathies that we can diagnose in pregnancy. Here we see another case, polydactyly, enlarged kidneys, and cephalocele. The combination does not always need to appear together, but this is the classic presentation. a combination of cranial and spinal defect in anencephaly. So first we try to measure the CRL, and we have big difficulty measuring the CRL because we don't know where it starts and where it ends. We have a significant curvature of the neck and spine, and associated with opening of the calvaria. And this is 10 weeks, this is 12 weeks. We also see fused kidneys, and this is another case at 12 weeks. So again, the lack of the anatomy of the brain here. We also had diastematomyelia at some levels in the abdominal spine. So we are going to speak about spinal diaphragms that may then content. They may be closed by skin and open, content only fluid and meninges and neural tissue, and sometimes also they are not covered, not even by membrane, which are the schises, so the rocky schises. There is a wide range of malformations, remembering that although many times they are isolated, but they may have associated anomalies that will be significant for the prognosis and the counseling, remembering that many cases in different places could be candidates for intrautero repair of spina bifida, that it's mostly performed before 25 weeks. Remember the association, the schisis association theories with other abnormalities as well. There are some classifications. I won't enter this matter, but I just want you guys to know that there are different classifications according to the anatomic histological criteria, or to the type of the abnormality, if it's open, if it's occult, and if it's latent. So here the bird separates the occult dysgraphic abnormalities, which are the ones that are had some mass protruding outside, and the latent, the ones that we are not going quite to see from the outside. We have also another classification from the embryologic criteria, which is very interesting. So which is the process that is involved in the abnormality that we see. And this is a must read. It's a very interesting recent paper from pediatric radiology from the European Society of Pediatric Radiology that describe how to check the normal and the abnormal spinal cord. They also classify criteria for the diagnosis of closed and open neural tube defects. So the presence of Chiari, the neural placode, the abnormal vertebral laminae, they are the major criteria for open neural tube defects. And there are other minor criteria: muscular atrophy, abnormal position, so club feet, nerve roots inside the sac, microcephaly, dysgenesis of the corpus callosum associated. So it's a very interesting paper that I also want you guys to know. So again, we can check, we can screen for the presence of spina bifida using the intracranial translucency sign, which is the obliteration of the fourth ventricle. We have the brainstem, the fourth ventricle, and the cisterna magna. So I really like to call it anatomically. So whenever we have the retraction of the brainstem closing the fourth ventricle, the cisterna magna, we will have the disappearance of this fluid in the posterior fossa. We can also check in the axial views the retraction of the midbrain posteriorly, which is called the crash sign. We can check for the proportions between the lateral ventricle and the choroid plexus to check for the presence of ventriculomegaly as well. So we have different screening, imaging screening tests that can be performed from the first trimester. But I want to show you some pitfalls. And this is a first case. Many of people that have seen my lectures have already seen this case, but this is a fetus that came for nuchotranslucency, and this is an exam from the real life. So patients are not always perfect imaginologically speaking. So sometimes the exams are hard. So, and I don't bring only very, very perfect pictures, but here it looks quite okay. I don't have the perfect cut for the fetal medicine foundation, but the nuchotranslucency looks okay, and we check grossly on the fetus, and the fetus looks fine. Okay, here we have the other side. We see the, grossly speaking, we don't see a very major abnormality. But if we check closely, we see that the profile is a little deep. Here we see the lateral ventricles as well, but there is something that it's lacking in this brain, which is fluid around the brain. And if we just change our probe 90 degrees, we see the huge defect. Okay, so how come we have a defect that it's almost the size of the head and we didn't see it? And I'll go back. And this is because the fetal head is shadowing it. Okay, so the defect is here. Now we are all quite more intelligent and we see it. But remembering the importance of doing the axial sweep and then checking for defects, also abdominal closure defects as well. This is another very, very interesting recent case. So the patient was sent to us because an increased nuchotranslucency. The butterfly sign was a little weird, we could say. So it looked like it had more fluid. We couldn't really see the three spaces or the three black lines. Here, the posterior aspect was quite different, and it looked like we had a crush sign. So in this first scan, we really suspected on the presence of spina bifida. We went to transvaginal, we check on the vertebra, and it looked that it was quite open, and we had an abnormal site of the fetal vertebra. But we asked the patient to come back again, and then when she came back at 13 weeks, then the cerebellum looked okay with fluid in the cisterna magna, and we couldn't see any defect. And at 17 weeks, posterior fossa was completely well developed, and the spine was okay. So this is also for us to remember that false positives may occur, and we should be very, very careful before taking our conclusions if we don't have a direct sign of the defect, even if our screening site is very, very suggestive. So let's check for the spine, and this is 9 weeks. This is 11 weeks. Okay, so we can already see. So I invite you guys to go and check directly on the spine. This is a very important thing to do, even when you see the clear-cut secondary sign for the presence of an open neural 2 defect, which is Chiari 2 malformation. This is the dry brain. So it's a difficult brain to scan because we have no fluid around. The ventricles are quite angulated, and we see the lemon sign, which is the abnormal shape of the calvaria. This case was difficult to check because we didn't have a sac. We had a defect, an open defect, but we had a schisis, and we didn't have a celle, so we have an open vertebra, and it was quite harder to check. So remembering that this Chiari 2 malformation is much more complex than a hindbrain herniation through the foramen magnum, and it comprises different abnormalities that we really, really don't know don't know how to explain them exactly. If they are, especially the malformations of cortical development, the heterotopias that may appear, and the callosal abnormalities, if they are secondary to the traction and the mechanical forces, or if they are primary to the underlying disease, but they may appear and may be a game changer for the decision-making process. So here the MRI shows very nicely how the brain is dry from the fluids around. We can have syringomelia, and here we see a cystic cavity within the central canal of the medulla, abnormalities of the corpus callosum, agenesis of the septum, heterotopias, periventricular,
Dr. Karina.
Yes.
Sorry to interrupt. It's only 1 minute remaining now.
Okay, thank you. And you are going to listen to our colleagues later on the surgical interventions and what are the prognostic factors that can be discussed for the establishment of the indication. And there is today discussion in the literature regarding whether we use the anatomical level of the lesion or if we use the motor, the functional level of the lesion. We know that there is also a change sometimes in the motor level of the lesion from the time of diagnosis to the time of the intervention. And there are strategies that can be, and I'm sure that they will be discussed, that can be used in order to establish the anatomical level of the lesion. We can count from the rib, we can count from the last vertebra ossified, and we can use ultrasound in order to check our motor level of the lesion. And I will end my talk because we could also speak about closed defects that can be diagnosed earlier as well, but they will be discussed in a further lecture. I will stop with the last case. This is 15 weeks. We see the shape of the calvaria. We see the banana sign, which is the cerebellum that is tracted downwards, the midbrain that is tracted downwards as well. Okay, so this would be the second trimester translation of the crush sign, the angulated ventricles, and here is the classic site of the myelomeningocele with the placode and the neural tissue going through the defect. We can count from the lower vertebra and we see where is the change in angulation. This will be the transition between the L5 and the S1, and this can be an anatomical site for us to start counting. One of the techniques. Here we see the cord that goes out, the cord that it will be always tethered in these cases and then goes out through the defect. And the prognosis, one of the prognostic factors for success of the interventions will be also at the anatomical level of the lesion, the size of the defect, and the selles have better prognosis than the schisis. And I hope the surgeons will be able to discuss this matter in order to explain to us why they are important prognostic factors. I hope we have brought a little light into how we can use our sonographic tool to make diagnosis and to scrutinize the anatomy for the diagnosis of these entities. Thank you so much, and I'll be open for questions.
Thank you, Dr. Karina. It's really early is better than late, of course. It's a good start to the day. Now I welcome a well-known fetal surgeon, Mauricio Herrera. He is the creator of Latino American Center for Fetal Surgery. And we hand over the stage to him for his amazing videos.
Okay. Thank you. First, I want to say thank you for this amazing conference and the first Fetal Brain Congress. I have also to congratulate to all the organizing committee and special to Prashant and also to Gustavo, because it's an amazing sensation to see many countries around the world here with more than 300 delegates on site and more than 50 countries and delegates from 50 countries in the online version. It's an amazing and new challenge for us. And I did some posts in the social media because I think that the Fetal Brain joined us, and it's an amazing opportunity to share the knowledge. Okay, today I'm going to share with you an introduction. Karina did an amazing approach regarding to the early diagnosis, but it is important also to take in account the outcome and the secondary effects of the open neural tooth defect, and especially the spina bifida. The data that we are going to show you today is from two institutions. I am working actually in two institutions. The first one in Colombia, the Columbia University Clinic, who is part of a big network of hospitals in 7 countries with KRLT and clinical consultants. And the second one, since 1 year ago, I am working here in UAE, in Abu Dhabi, in Burjil Medical City. And we have the amazing opportunity to create 2 hubs for fetal surgery and therapy. And actually, in the last year, we did 139 fetal surgeries in these both centers. Regarding to the fetal therapy and fetal neurology, actually around the world, we are working on the possibility to consider the fetal surgery and the framing in utero in the cephalocell, and also in some cases with the secondary effect with severe ventriculomegaly. And the third is the open spina bifida, and specifically the myelomeningocele. And if you see some papers around the world, we are working on that because it's very important to improve the outcome and improve the neurologic prognosis in this kind of babies, because the intrauterine changes can be stopped regarding to the congenital malformation in the fetal brain or in the fetal spine. I have to say first that not all the cases are eligible for the fetal surgery in utero. That is very important point. And the other important point is that all the procedures that we are doing actually in fetal neurology have to be validated, because we have to be sure regarding to the good effect about the intrauterine fetal therapy. And all the cases have to be evaluated for consider different techniques, because as you can imagine, it's not the same if you have the placenta anterior, posterior, lateral, or many other considerations that we are going to see during the lecture. The other important conclusion from our point of view is that any center around the world that is doing in utero fetal surgery for the open neural tooth defect, and specifically for myelomeningocele, has to be prepared to do both techniques, the fetoscopic technique and also the open surgery, and have to have in the team the maternal fetal medicine specialist, the neurosurgeon, and the pediatric surgeon as a part of the multidisciplinary. Regarding to the history in fetal surgery, and specifically in the fetal neurology, we have to consider Professor Brunner regarding to the open fetal surgery, and also the Professor Axi from the US. It is important also that that kind of data from this first procedure increase the possibility to access to the womb and to the amniotic cavity to offer to the fetus the possibility of some of treatment. Karina already did an amazing approach to the definition of the open neural effect. And I want to say something regarding to the physiopathology and the justification for consider the fetal therapy in this kind of pathology. You have to take into account the fetal brain changes. And the most important changes regarding to the Arnold-Chiari type 2 malformations. And the changes in the fetal brain obviously has a secondary effect, not only in the anatomy, not only because the ventriculomegaly, only that kind of changes has an important secondary effect in the cortical development, and all obviously depends on the severity of the secondary changes, and also obviously depend of secondary findings, like for example the intraventricular hemorrhage or changes in the posterior fossa. Well, if you remember, we have to take into account three important points. The first one is the lesion, and we have to be agreed that the open spina bifida is an embryological problem. Okay, that means that with the surgery we are not going to fix the embryological problem, but also we know that the normal evolution inside the utero with the spina bifida, secondary to the exposure of to the amniotic fluid of the lamina terminalis and also obviously of the medulla, has an enormous and big and huge effect in the neurological system. That is because we have to consider the surgery and increase the possibility to reduce this secondary effect. This is a beautiful paper. I recommend, if you are interested to know how the defect can produce inflammation, and this embryological damage can produce not only neurological abnormalities, and also the inflammation can produce another changes in the muscle, for example, and reduce the normal development of the muscles, and obviously produce another important effect in the fetal brain, specifically in the fetal central nervous system. And if you remember, the insult to both central and peripheral nervous system may be progressive, and in some changes can be different. And the other important point is regarding to the two-hit hypothesis. The first one is regarding to the failure of the neural tube closure and the exposition of the neuroepithelium to the amniotic fluid, but also the inflammation during the pregnancy is another important point to take in account. The second hit is secondary to the degeneration of the exposed spinal cord. And that means that we have two important points in the physiopathology. The damage, specifically in the hole in the spine, and the damage inside of the fetal brain. Obviously, the exposition of the exposure causes an hemorrhage, the degeneration, of the neural tissue, the abrasion, the erosion, and the complete loss of the dorsal region of the neural tissue. And the other important point to consider is the toxicity. For the prenatal diagnosis, Karina already did and give us an important point for the pattern of recognition in the early diagnosis, and obviously the confirmed diagnosis in the second trimester. Remember the lemon sign and the changes in the posterior fossa, the Chiari malformation changes we are going to see in the next slide that is important to take in account. Okay, we are going to talk about the two specific techniques that we are doing actually. The MAIOS, the myelomeningocele open fetal surgery, and MAIFES, that is the myelomeningocele fluoroscopy surgery technique. For this kind of consideration, we have to take into account that we create, specifically in the open surgery, we create 15 steps that we do have to take into account for the increase the success of the fetal surgery. I'm going to show you the typical case about the open spina bifida. These are a fetus with 22 weeks, and you can see the ventriculomegaly, the symmetric bilateral ventriculomegaly, the abnormal anatomy of the posterior fossa, the abnormal anatomy, the cerebellum, and you can see in the coronal planes also these important images with the collapse of the subarachnoid space. That is because the open and the secondary changes in the fetal brain because the spina bifida. In all the cases, we are doing pillar MRI. And you can see here the changes, the same changes in the fetal brain with the abnormal anatomy and the fall of the cerebellum. And you can see the obliteration of the foreventricle. Obviously, you can see the collapse of the subarachnoid space and the ventriculomegaly. Also, it is important to consider another anatomic point, and the placental position is very important, and also you have to analyze with the ultrasound and obviously with the fetal MRI, you have to analyze the secondary effects of the open neural effect, in this case regarding to the myelomeningocele. And we are going to talk about have to rule out the possibility and other abnormalities, and you have to rule out the syndromic conditions in the spina bifida. The outcome, it's very evident that the contraindications, in the fetal surgery are, you have to consider relative contraindications like technical difficulties, and the other important point is uterine malformation. We consider absolute contraindications, for example, the short cervix, the previous placenta, or the abnormal placental implantation, the body mass index, the BMI more than 40, the history of preterm delivery, and some of infection like HIV, hepatitis B, hepatitis C, or any other maternal pathology that contraindicated the general anesthesia for both techniques. The postoperative management after the surgery, I'm going to describe step by step the fetal surgery in both techniques. You have to take into account that the patient needs the tocolysis. We are actually in our protocol, we use the magnesium, the intravenous analgesic, and the local and regional anesthetic technique. And it is important to consider the hemodynamic monitoring of the patient during the surgery. Regarding to the anesthesia, we are using general anesthesia with regional anesthesia to reduce the contraction after the procedures. And it is important to take into account also the duration of the procedure. In our center, actually, we are between 45 to 75 minutes in both techniques. Depends obviously on the severity of the defect and the size of the defect. The selection criteria is the signal pregnancy between 19 to 26 weeks. The level of the lesion, as Karina says, is very important, and obviously the secondary effects of the lesion. We need the genetic test or rule out the possibility of syndromic association, and without other congenital abnormalities, as you can imagine. And for us, it is very important to follow up the patient, at least the first 4 weeks. That is very important to consider. In the open field surgery, we are doing a small hysterotomy that we call the rhomboideal hysterotomy. Okay, I'm going to describe it exactly regarding to the technique. And for that, I'm going to use this video that we are doing in all our procedures. I'm putting a camera in my head, and we are going to see the most important points regarding to the technique. We deliver the uterus and put the uterus outside, and we are doing an transversal laparotomy that we call biliar laparotomy for the luxation of the uterus in both techniques. Why? Because we have to reduce the possibility of complication regarding to the position of the placenta. As you can see, this is a conventional laparotomy. We have to be very obsessive with the control of the bleeding at the moment of the access. And the other important point regarding to the site of the laparotomy, because we have to reduce the pressure in the uterine artery at the moment to put the uterus outside of the maternal abdomen. The other important point is the mapping and planning. We call mapping and planning in all the fetal surgery techniques that because we have to make a complete review of the anatomy of the moment preview of the fetal surgery. You see, I am doing here the mapping and planning, and we have to localize the placenta, and we have to choose the safe zone for the hysterotomy and for the access with the trocar for the fetoscopic technique. That means that also we have to put the defect. I mean, we have to put the spine of the fetus in the exact site for access, okay, for, to the defect. We have to reduce the possibility to move the baby, okay, because we have to reduce the hemodynamic changes for the baby, okay? That means that we have to put the baby in cephalic position. And I call that technique the jumping technique, okay? We put the baby in all the cases in cephalic position. And we are doing this kind of landmarks in the uterine surface for localize the placenta because the access to in the open technique and the insertion of the trocar have to be at least 3 centimeters far of the border of the implantation of the placenta. That will reduce the complication with the placental insertions, hematomes, bleeding, whatever. After that, after the landmarks, if you need, in some cases, we are using the amnioinfusion because we need to put the baby in the accurate position. The second surgeon has to keep the baby in cephalic position or put the lesion in exactly side. And you have to, in the open fetal surgery and in the fetoscopic surgery, at the moment that the insertion of the vascular catheter, we are doing the access exactly to the lesion, okay? You are going to see it in this moment. Another important point is the stitches. In both techniques, you have to use the stitches for the fixation of the membrane, or reduce the possibility of trauma, okay? And we are using a rhomboideal incision, and we are using 4 stitches. Why? Because we have to reduce the vascularization, okay, in the zone of the access, or reduce the bleeding, reduce the possibility of inflammation. And it is an amazing, I learned this from the plastic surgeon. because we have to reduce the tension in the uterine wall. That is because actually we're having an amazing results with our technique with very low rate of PROM, and obviously with the median of the gestational age at the moment of the delivery is 36 weeks. Look at the stitches, and we are doing 4 stitches for the rhomboideal incision. And why a rhomboideal incision? This is another learning from the plastic surgeon, because as you can imagine, you are doing this kind of incision in a muscle, and you have to reduce the tension. And I'm going to show you this important point. And this is the rhomboideal incision. And we have to be very carefully with the dissection because we need to open the amniotic membranes or catch the amniotic fluids in this angle, okay? As you can see, this is the rhomboideal incision. The diameter is 2.5 centimeter. And if we need, we move the baby because the size, if the size is more than 2 centimeters, we move the baby in the open technique for the neurosurgeon and for show the lesion to the neurosurgeon and improve the times of execution. As you can see, we catch the amniotic fluid. You have to avoid the possibility of the contamination with the bleeding, and the neurosurgeon start with the closing in 3 layers, okay? If the neurosurgeon see the requirement to use the dura mater patch, obviously the neurosurgeon is going to use it. About the closing of the uterus, is very important in the open technique to use 3 layers, but in opposite direction that you did the rhomboideal incision. That is because we, until now, do not have any complication, any uterine rupture in our cases, okay? As you can see, at the end of the surgery, you can see here that we are doing 3 layers, and the last one is an opposition of the tissue because we have to reduce the possibility of the uterine perforation. The other important point for the objectives of the surgery is the brain change, okay? And look at the fetal MRI 4 weeks after the procedure. As you can see, the normal suranoid space, as you can see here, the normal anatomy in the posterior fossa, that means improving the condition for the fetal brain after the surgery. This is some example. This is the case 4. You can see the scar of the baby with a complete closing in the open surgery. And you can see here the uterine scar. As you see, it is very interesting that the 3rd layer in all the cases is going to be open, okay? The 1st layer and the 2nd layer is going to keep, okay, closing the uterine surface. This is the case 5, for example. This is the uterine scar in the posterior wall, okay? And this is the scar of the baby. This is the case 20, one patient from Ecuador. You can see the baby's scar, and also in the posterior fossa, in the posterior wall of the uterus, you can see here the uterine scar. This is the case 22. Look at the fetal scar and look at the uterine wall and the uterine surface. Actually, this is our closing technique, and we have to reduce the possibility of any complication and reduce the possibility of fistulas regarding to this kind of procedure. The second procedure is the fetoscopic technique. The fetoscopic technique, we are using the fetoscopic technique for the small effect, less than 2 centimeters, because we have to be sure that we can close, okay, the fetal skin without the requirement of the lateral incision in the skin of the baby for relaxation of the tissue. We we believe that this kind of secondary techniques is not necessary because you are improving, or you are increasing the possibility of infection, okay, lesions in the muscles in the baby's back, and that is very important in all the consideration the technique. In the fetoscopy technique, we are doing the fetoscopy technique with the pediatric surgeon and the neurosurgeon. Obviously, we have to use the accurate instrument, and for the instrument, we are using a 3 millimeter diameter endoscopic instrument that you know the pediatric surgeon is using in the pediatric endoscopic surgery. We are using the same. We are using 3 ports for access to the amniotic cavity. Obviously, you have to do the same technique, mapping and planning the Langerhans in the uterine surface. As you can see here, I'm going to show you the access to the amniotic cavity with the first one insertion with the ultrasound guided of the trocar. This is the second trocar with a direct vision, and we start with the dissection, and the pediatric surgeon with the neurosurgeon start with the dissection by endoscopy, the dissection of the 3 layers. The first one, the fetal skin, the second one, the muscle, and the third one, the dura mater and the meninges. Obviously, we have to use in most of the cases the dura mater patch, as you can see here, for reduce the possibility of fistula and improving the inflammation, reduce the inflammation in the neural. Okay, what are the new technology and the new developments for the last segment of the last 3 minutes of my lecture? This is, for me, it's very important to share the knowledge. And I think that actually in the world, it's not possible to offer a complete training in this kind of technique. That is because we create in our fetal lab, we are creating the technology to offer to many centers around the world the possibility to increase the number. But the second, to give the training to all the team that include not only the maternal fetal medicine surgeon, the pediatric surgeon, the neurosurgeon, also include the anesthesiologist, also include the midwife, also include the specific team from the theater. We create these 3D printing babies, and this is, I have to say, it is an idea from my daughter, Mariana. She loved the technology, and she pushed me 4 years ago to start in the 3D print technique. And it's an amazing because we create, this is our baby, and we are doing all the defects in the baby, improving the possibility to create the phantoms for the fetal surgery. Also, we create a uterine, the synthetic uterus. Let me show you. These are the models. We are using a piece of chicken, for example. We use a plastic cover, and you can see here the 3 layers. That is exactly the same sensation that the pediatric and neurosurgeon, okay, have at the moment of the surgery. You can see the 3 layers, and we are doing this kind of procedure in our center. The other important point is that also we are using real cadavers, okay? And this is part of our technique. Let me show you very fast. This is using our synthetic uterus. Look at the same anatomy and the same sensation that in the insertion of the trocars, and we are using the same instrument in the pediatric surgeon, and we create the defect in the fetal cadaver. In the conclusions, it is important that all the centers have to be prepared to do both techniques. Obviously, this kind of treatments and the fetal surgery do not depend only one person. It's a complete team, okay? And that is very important for all the centers around the world, okay? The surgery in fetal in myelomeningocele and spina bifida is progressing very, very fast. And currently, the open surgery is the only one validated fetal therapy for the open neural. And we have to work under trials for validate the fetoscopy technique. Thank you for your attention.
Thank you, Dr. Mauricio. That was really a treat to watch. I mean, something. Yes, sir.
Yes.
Full talk. Two questions.
Yeah.
One is, what is the cost for surgery if somebody from India has to come to Abu Dhabi? Number two, we talk a lot about anatomical levels. So if we see normal fetal limb movements and bladder and kidney, how relevant is it to rule out a neurological problem from the
Okay.
pre-surgical point of view and post-operative counseling?
Okay, the first question regarding to the cost, the good notice for the low-income countries around the world is that we, through my foundation, we have a lot of grants for help this kind of patients. The cost is zero. Okay, and this is because in UAE, the interest is to help the people with high technology. Actually, the next week I have 3 spina bifidas from patients from Latin America. That's an amazing possibility for the patient. The second important point regarding to the level and to evaluate in the correct form the secondary change of the neurological damage, you have to take in account the level of the lesion, okay? The first, this is very important. And the second important point for the neurological evaluation is you have to do a complete evaluation of the fetal brain, okay? Have to look for intraventricular hemorrhage that is very frequently, okay? In our cases, almost between, and I spoke with Daniela, and she saw the same in the fetal MRI in her cases. You have to rule out the intraventricular hemorrhage and the posterior fossa hemorrhage, okay? And the other important point is other clinical manifestation that, like the croup foot, is very important, okay? And the other, the hypotrophic, okay, status of the muscle in the leg, okay? The no, you know, the normal movement of the fetal leg, that's very important. For that, we are using the ultrasound and the fetal MRI. The dynamic fetal MRI is an amazing tool for the evaluation of the neurological impact in the open.
Thank you.
Thank you, sir.
Okay.
We will take further questions in lunchtime or dinner time.
Thank you.
Now we move on to the further topic. It's a recorded session. We dive deeper into.
Good morning, everybody. Good morning, ladies and gentlemen, esteemed colleagues, organizers.
Good morning, Prof. We welcome Professor Jose Piero. He is a professor of surgery from University of Cincinnati and also a director of Cincinnati Children's Fetal Care Center. We can start, sir.
Good morning, everybody. Good morning, ladies and gentlemen, esteemed colleagues, organizers. It's a truly a privilege to stand before you today and explore this topic that represents a remarkable medical innovation and that provides a brighter future for expectant parents and their unborn children. Today we will go in a journey into the domain of the prenatal therapy, focusing our attention on the minimal invasive fetal surgery, a group-breaking approach for fetal prenatal spina bifida repair. We will try to achieve some learning objective like understand the physiopathology of the spina bifida, identify the rationale for offering prenatal repair, discuss the different fetoscopic approaches that are right now worldwide, analyze risk and benefits of fetoscopic spina bifida repair, and emphasize how important is multidisciplinary collaboration. We will review outcomes and long-term implications at some point and explore ongoing research and innovations that we are trying to implement. So this is the actual picture of a newborn with an spina bifida that are very familiar for everybody of us. And we need to know that spina bifida is the most common permanently disabling birth defect worldwide. It's not very frequent, but still is 1 or 2 cases per 1,000 live births worldwide. So it's a lot of new cases every year in the world. And all the problem comes from a very simple thing. At around 4 weeks of gestation in the embryo, there is a lack of neurulation in one part of the spinal cord. The normal neurulation can fail, usually in the lumbar sacral area. So the closure of the spinal cord in the embryo is like a zip up and down from the middle of the back. And then once we have that area that is not well closed, so we have the spinal cord open like a book, exposed to the outside. So this malformation itself is not making any problem in the structure of the spinal cord besides the shape and the non-being covered. So this is the first hit. The problem comes with the second hit. Second hit is the contact of this neural tissue to the meconium that is diluted in the amniotic fluid. And we know that that produces a damage and progressive neurologic injury in this spinal cord. There is recently described a third hit that is in the cases of a myelomeningocele with a sac, with a large sac, the spinal placoid is completely extruded outside the body and the nerves are under stretch. So this stretching of the nerve roots makes a big impact in the motility and the deformity of the feet. As you can see here in this MRI, we can expect in these large lesions will fit. But coming back to the second hit, so we know there is neuroinflammation at the time of delivery, and as I explained it, because the amniotic fluid contact, but actually the question is what's the actual neural damage? So our lab is working hard in this model of spina bifida in different animal models, and the idea of the lab is just to be translational and go from the bench to the bedside and vice versa. So this is one important question. So this is our lab that is composed by fetal surgeons, neurosurgeons, neuroscientists, postdoc researchers, engineers, maternal fetal specialists, medical students, etc., etc. And the overview of everybody makes a big impact in our projects. So answering that question, so we know that in this retinoic acid rodent model, so we can see how the spinal cord is being destroyed during the pregnancy. So that is why we say it is a progressive injury. And also, putting the artesunate AT in pregnant rats, we can generate spina bifida occulta, but also spina bifida aperta, and this is a very nice model for comparison. So we know that this neuroinflammation, we have reactive microglia in these cases of spina bifida. And also we have reactive arteriolysis. So it's the scar. So we have macrophages, activated neuroinflammation, scars in this exposed tissue. And finally, we can see apoptosis and neuronal cell death. So it's like an onion that is losing layers of cells. In this case, we are losing very valuable neurons. And also, we discovered recently that all the neuroprogenitor cells that here you can see in green around the ependyma, they are compromised their fate, so not to be any more neurons, and they become like astrocytes to generate the scar. So that makes all the problem in these babies at delivery. So what we have when a newborn is in front of us is a defect, open defect with a lot of neuroinflammation, and the first reaction and the first treatment is to do the repair as soon as possible to avoid infections. But it's too late because sometimes we have the process very advanced and we have all the neuroinflammation implanted. So we need to assume all the known sequelae of this condition. So all the urinary, intestinal, sexual dysfunctions, orthopedic anomalies, and also motor deficits. But not only distally, also central. In the encephalic area, we can find the cerebellum is herniated, so the hindbrain herniation, right, with the Arnold-Chiari type 2 malformation, and also secondary to that, obstruction that build up fluid in the lateral ventricles, generating hydrocephalus. So almost 90% of the cases of fetuses more than 24 weeks, we will generate hydrocephalus. And also, this hydrocephalus can be associated with heterotopias, brain malformations, neural migration disorders. And as you know, these babies postnatally will have a lot of problems with these shuntings, with ventriculoperitoneal shunting that require several revisions, et cetera, et cetera. So the first step to avoid all this is just to have a good prenatal diagnosis. And from that, we can detect these malformations, as you know, very early in gestation, just with the fruit signs, the banana and the lemon sign, okay, just we can see these encephalic problems. And then from there, we can go down to the spinal cord. The spinal cord in a fetus is normal. We can see the ossification centers in the spine, all right, in a triangular configuration. And also in the sagittal view, we can see these two parallel echogenic lines. This is the normal. But in MMC, we will see the defect of these lines, right? And also in some cases, when it's cystic, we can detect perfectly well the cyst at the lumbosacral level. Here in this video, you can see how we can identify this cystic MMC at the end of the spinal cord, at the end of the spine. 3D reconstruction with ultrasound also can be very helpful to figure it out how this lesion looks. And most importantly, the fetal MRI can complement this ultrasound by seeing the defect size, by seeing the crowded posterior fossa and the hindbrain herniation besides the hydrocephalus. Sometimes when you have any concern about a closer defect, we will see another lecture later. Very important thing to do is just to take amniotic fluid, not only for karyotype and genetic analysis, also for doing acetylcholinesterase, that in case it's positive, we can conclude that it's an open neural 2 defect. Obviously, we need to monitor the ventricles and identify if it is ventriculomegaly. And we know that after 15 millimeters, the chances to avoid postnatal shunt is very reduced, even with prenatal surgery. Also, ultrasound is very important to determine the level, the anatomical level where the bones are split. Okay, so we can identify the last rib at the T12 and then count down until the defect is characterized. Recently, what we implemented is also to do by ultrasound an estimation of the functional neurological level. So how these fetus are moving, the extremities, how these fetus are flexor extension, the ankle, by 3D, 4D ultrasound, or just by regular active conventional ultrasound. So we described it a few years ago, we published this technique, so how we can estimate this functional level, but at the end, the goal will be just to preserve that movement. And we do the same as we will do in a neonate, so just explore how this baby's flexor extension and correlate that with the metameric level. So here you can see how we can analyze for many minutes the active movements of the ankles and the knees and the hips. So every single movement, active movement, will correspond to a muscle and a segment and a metameric level. And also this affectation, we can extrapolate what we expect postnatally in case that level stays like that. So it's very difficult and very different to have a baby that can walk or a baby that already have impairment and needs to go in a wheelchair. This is very common to have in our reports in the ultrasound, how we describe this club foot and if there is motility, ankle, plantar flexion, extension, etc., etc. So with all that information, we can do a good counseling and offer options to families. So in some countries, termination of pregnancy is legal, and it's an option that these families can have, but also they can decide just to have a baby and do a postnatal treatment, surgery of this spina bifida, but obviously we need to assume, as we said before, all these neurological sequelae. If their alternative right now is to do prenatal surgery, try to protect this neural tissue and try to prevent many of the problems of these babies. Again, to review the physiopathology, so the meconium diluted in the amniotic fluid is clearly damaging the nerves and the racote that are responsible for the motor deficits, and also the leakage, the leak on the CSF at the level of the defect will produce increase in the chial malformation and the hindbrain herniation, and obviously the obstruction will build up fluid and generate hydrocephalus. To avoid both problems, just by repair in a watertight fashion will potentially improve all these problems. Here you can see some images of open fetal surgery with a cystic defect, with a primary repair with skin closure, or sometimes it's not possible, so we need to do closure with a allograft patch just as a skin substitute. So that's the rationale of fetal surgery and what was based at the MOMS trial with a very clear inclusion and exclusion criteria, everybody we know, and then repair by the neurosurgeon with exposed fetus and back of the fetus with a defect. So then the conclusions of the MOMS trial, you know, that is there are some benefits for the babies, basically reduce to half the needs of shunting, improve the score of mental and motor outcomes at 30 months. Most of the cases we can revert the hemorrhagic herniation, and obviously we can improve the ambulation. All these benefits are counteracted by the potential maternal and fetal risks, basically prematurity. The cases we did in Cincinnati by open fetal surgery are close to 60, and still we are offering, but as you know, this opening in the back of the baby produce some kind of problems, mostly prematurity. We have good results with the primary repair, as you can see here, or using patches here in these repairs of these babies by open fetal surgery. Also, we have good recovery, reversion of the chiari malformation in this series of 60 cases. And also, as the MOMS trials, we reduce the shunt needs with the prenatal surgery. So that's benefits, but still we have significant prematurity. Still in our hands, the overall delivery is around 34 weeks. So all the fetal surgeons we are working in this field, we are looking for minimally invasive surgery, mostly on the uterus. And that's why we are exploring on fetoscopy. So I have been working in this field for many years when I was in Barcelona and in the last 10 years in Cincinnati. So we thought that we can treat many fetal conditions by minimally invasive fetoscopic surgery. We have more than 1,500 laser cases and fetoscopic cases for all the conditions. So also, as the pediatric surgeons working with neonates, we have skills in laparoscopic and thoracoscopic neonatal surgery in small spaces. So why not to implement all these skills to fetoscopic spina bifida repair. That's why we have the hypothesis to repair and close the skin in utero with these small instruments. So I started in Barcelona just creating models in fetal lamps, just recreating the spina bifida. It's a very good model that recreates the human by a laminectomy, opening the dural sac and myelotomy. We can recreate perfectly well these defects and all the consequences postnatally. So by fetoscopy, we try different strategies like using patches, using glues, using stitches. So with that, as you can see here, so we can have a good defect in the back after 3 weeks of the creation and then try to repair. So clearly the non-repair model reproduced the paralysis in the posterior legs, also the key malformation and the injury in the spinal cord by histology. And the repaired cases can work, can have a good preserved plaque and also revert the Chiari in these animals. So that was a lot of generated a lot of publications with different strategies, but that enhanced our idea to move to the clinical trial just to do fetal surgery. But just before we started to do simulation by fetoscopy in models that we created, so we can just practice with chicken skin, etc., just to do increase our skills. So you can see here it's a model of a ball with a chicken skin covering. So we can do just patch placement, suturing. You can see here how we can practice with the camera and the 2 ports just to close the skin in spina bifida. So with all that work previously done, we were ready to jump from the animal to the human clinic. And that's what we did. So this is our setting right now that we implemented from last 10 years. And we started with 2 3mm trocars and 1 2mm trocar, 6 French and 10 French. And the key is just to remove half of the amniotic fluid and replace that with CO2, but a very special CO2, which is CO2 humidified, okay, and also warm at body temperature. So it's like creating a camera of a wet sauna that maintains the fetus very stable, very comfortable, even for 2 or 3 hours if it's required in this surgery. So when we go back in the time about fetoscopic MMC repair, we need to say that in 1997 was published the first work, the first 4 cases by the group in Vanderbilt by Noel Tulipan and Joseph Brunner. So they did a very similar approach as we did, right? So they used a maternal skin just to place in the defect and close the defect. Obviously, they didn't use this humidified warm CO2, but they was very close to this approach. The results they had were not very encouraging, so they moved it to the open fetal surgery to be more appropriate and better quality of the closure. But if we talk about fetoscopic MMC, besides that and tested in 97, so was Thomas Kohl in Germany that started to do the percutaneous approach for fetoscopy in 2003, still doing. And then was Denise Pedreira, now Denise Lapa in Brazil, in Sao Paulo, that she started 10 years after in 2013. Our group in Barcelona, we started in between these 2 groups. So we started in 2012 to do clinical trial before, after the animal project. And my group in Barcelona, we decided to expose the uterus and mobilize the fetus in a good position, place the 3 trocars, and then at the time of removal, close the membranes and the uterus with a stitch. We started with 2 trocars and trying to use a patch and a glue technique. And then we realized that the glue was not always trustable, so we moved it to the suture on the skin. So with this technique of 2 trocars, we collaborated with a group in Houston. So they still are using 2 trocars in Baylor. But after my move to Cincinnati, I'm joining my partner Lim. So we decided to move to 3 trocars and to do the closure by suture. So this was the first groups in USA doing fetoscopic MMC. After that, there was a spread of other groups in other countries. So we have good relationship with Argentina, Mexico, and all the centers in USA that are using the same approach we are doing. by exposed uterus by assisted laparotomy, fetoscopic repair. And other groups are also adopting the completely percutaneous, that they don't close the membranes, and obviously they have a little bit more rupture of membranes and preterm delivery than us. There was a mixture of techniques and many groups doing this. So we decided, I personally decided in 2017 to invite everybody to Cincinnati and do a big meeting, a big symposium to establish an international registry and a fetoscopic MMC consortium. So this is the advertisement that we did in October 17. There was a very successful meeting. There was a very honest presentation for all the groups doing this. And then the next year was performed the same meeting in Monterrey, Mexico, and just before the pandemics that stopped a little bit all this. So this is the group we have in Cincinnati. So we have 2 fetal surgeons, 1 pediatric neurosurgeon, and 5 MFMs. Besides other groups, this is the core of the group, but we have obviously anesthesia, neonatology, nursing, everybody involved in this program. It's very important to stress it's not about one surgeon, it's about a big team and a very complex program. So this again, our approach. So we implement a camera of modified warm CO2, the 3 trokers, and you can see here the exposed uterus with the 3 triangulation trokers. So we are using barbed sutures just to close the defect in the skin and facilitate not making intercorporeal knots. We are using 3 and 2 millimeter instruments, very tiny and very precise. And the final goal is just to do primary skin closure, as you can see here. So we know that 74% of cases we can do primary closure, and only 1/4 of the cases we need to do another kind of closure. So the mean operative time in these cases is about 250 minutes. So skin to skin in moms. So it's a long procedure as well. Sometimes, as I say, we need to use an allograft patch as a skin substitute. As you can see here in this implantation, when the skin is very, very bad quality or very open, wide defect. And also, as I say, 25% of cases are requiring this kind of patch, and most of the cases are myeloseals. Thoracic cases, no sac. This is the setting. We can do ultrasound and Doppler continuously to monitor the well-being of the fetus. So we can see the contractility of the heart, heartbeats, avoid bradycardias, also the Dopplers on all the common vessels. So we can monitor this baby during the whole surgery. So again, we move in the last 20 cases to 3 trocars of 3 millimeters, 10 French, all 3. As you can see here, we started with Seldinger, just placing a stitch before to attach the membranes. And now we are preparing the sharp trocar to cut the membranes and go straight inside the uterus to avoid tenting. We did some changes just to try to make a box with external stitches with 4 PDS stitches, but we realized that it was not perfect. So now we're doing actually 1 U-shaped stitch with 2 separate knots outside just to complete the closure of the holes in the membranes. The other thing is important with the fetoscopy is we can have a very good magnification and very good quality of the defect. You can see here a meniscus 24 weeks, whole good detail of the anatomy represents this image. Of course, before doing anything in the fetus, we inject intramuscular in the buttock a cocktail of meconium, fentanyl, and atropine. In the first cases, we establish a stitch in the middle of the butt just to maintain stable position, but we are not doing any more of that because we are just skilled just to maintain the position and move easily inside the uterus. The detail that neurosurgeon can detach the placode and release from the tethering is amazing. So we can detether completely the placode and return the placode and the nerves to the spinal canal very easily. You can see here this MMC with a cyst and the placode in the top. All the detailed the resection of all the placode coming back to the cervical canal, to the spinal canal, we can do. Then there are people that do myofascial flaps. And we trust a lot in our open approach and also in the fetoscopic approach in dural substitutes. So we use a rolled patch, a dural patch that we can implement over the placoat. And actually, we do 2 layers. We overlap 2 patches with a stitch in each corner just to maintain the position. We are using umbilical cord matrix in 2 layers, as you can see here. And again, we are not against the myofascial flap that can be done by fetoscopy as well, but to avoid these cuttings and this extension of the time, we're still trusting on the patches, having good results with watertight closure. After that, the next step is to close the skin and be as much as possible watertight. Here you can see different closures. It's a sequence with a MMC, cystic, release the placoat, protection with a dual patch, closing of the skin. Again, the stitches we put at the beginning, we can close at the removal of the cannulas and have the closer holes in the uterus and in the membranes, as you can see internally and externally here in these images. These are babies that are delivering with the closure of the defect, so the absorbable sutures that we don't need to remove. As you can see here, all of here, very good results. And sometimes when we have primary repair, we have this aspect, but when we need to put the Allodone patch, we have this aspect that needs some epithelialization postnatally for a couple of 3 weeks with some dressings. This is a video that is double speed. So with the exposed uterus, we can just map the placenta, look for the wound place. This is a Seldinger entrance. We are not doing anymore. So we put a stitch just to maintain the trocar in place. And then we go inside with the camera, remove the fluid, CO2 amniotisation, warm, humidify it. So then we can see the position of the baby. So we can introduce the other 2 trocars just by direct visualization, whatever is Seldinger or sharp trocar. And this is the setting of the 3 trocars with the ultrasound control. Then inside, this is a MyeloSeal, so we can put anesthesia in the fetus. And in this case, we put this stitch in the middle of the back just to maintain position. As I say, we don't need any more. So we can coagulate the main vessels to avoid bleeding. And then the neurosurgeon usually dedicates to resect the sac and peel out and release all the placoat, all the nerves. You can see here whole 3R. And then it's the time for us to make skin flaps, trying to close the skin in the midline. Okay, and after these 2 sides skin flaps, we decide obviously to roll the patch after measurements. And this is the dual patch, okay, over the placoat with stitches. We can maintain fixed to one side and the other. And here you can see on the patch also being fixed in a corner. Once we have the 2 patches in place, we close the skin, right, crossing the loop with these valve sutures. And as you can see here, the closure of the skin is pretty nice. And we can finish the procedure, removing the gas, replacing the fluid, putting antibiotics, and closing the holes in the uterus and membranes. So far, we have 83 cases done in Cincinnati. So the first 20 cases were like a pilot safety and feasibility project that already we passed it. And this preliminary data serve as a next step we are doing right now to complete a prospective study to validate or not comparing fetoscopic approach with the open approach in our hands. And we are very happy about the results. So we know that by definition, we have less maternal morbidity. We don't create a scar in the uterus like the open. We can allow these moms to deliver vaginally. Actually, more than half of the patients deliver vaginally, otherwise it's obstetric contraindication. Our delivery date are right now close to 36 weeks, so close to term. So it's much better than the open fetal surgery, at least in our hands. And it's very important that we didn't saw any inferiority on the quality of the repair, and we don't see any inferiority on the neonatal outcomes. So actually, we have a very good recovery of the Chiari. So we have almost 90% improvement of the Chiari with a 77% complete reversal. Also, the CSF diversion is only 32%, right, in our series, and also very late in the postnatal life, not in the first days of life. The overall is like 7 months at the time we need the shunt in this part of the patients. And finally, the motor outcomes are pretty good. So we improve at least 2 levels better in 30% of patients. And we know that more than half of the patients can walk independently at 30 months of life. So just to finish, innovations we are trying to do in the lab and in our center is just we are with the engineers designing a new draw patch that have memory shape at temperature, spinal cord friendly, biodegradable, and also can be a carrier for medications like anti-inflammatory drugs. Also, we are working in regenerative stem cell therapy with amniotic fluid mesenchymal stem cells and neuroprogenital cells and neurospheres. So trying to do neural regeneration and restoration. So it's a lot of things we are doing right now. We are evolving very fast in this field of the spina bifida. Still a lot of things to do, a long way to go. And we like to enhance international collaboration and work together with other centers, with other countries, just mentoring other programs abroad, USA. And this is also a course that we do every year, not only by fetoscopy, we do a separate spina bifida course for teams that are interested to do it in the world, just to train our protocols and in this animal model of the fetal lamb to train all together. So this usually is in April. And just for conclusions, we will say that we are checking the efficacy of the prenatal fetoscopic repair, that there are different ways to do it, totally percutaneous or laparotomy assisted. We prefer the second one because we can close the holes. We actually reduce significantly the maternal morbidity with this approach. We are getting better gestational age, and hopefully in the future we can go for an early repair before 20 weeks. And also, we are very honest and very transparent with the families with the 2 approaches, so they finally decide if they want open or fetoscopic. Obviously, we need a multidisciplinary collaboration. It's not a question of one surgeon. I told that before. We are considering to go earlier in the station at some point, and still the limitations is we have some cases with preterm rupture of membranes with perimeter separation, and obviously we need to improve that. And in ongoing research, as you see before, we will increase the safety, the refinement, and the efficacy of these procedures by fetoscopy. So in our series, it's feasible. We have no conversions to open in more than 80 cases, knock on wood. We need more time than open fetal surgery, but the babies tolerate that pretty well. The correction is completely watertight, and we revert the Chiari in more than 90% of cases. We don't have any case of CSF leaks at delivery, only 3 cases with some skin dehiscence that heals by themselves. We can allow vaginal delivery more than half of the cases. And finally, we don't have any rupture of the uterus, obviously, with this minimal invasive approach. So this is some of our patients that moms join it in a park in Cincinnati, and it's an amazing picture of all the corrected bags. And this is my insights about this fetoscopic approach that we are doing right now in Cincinnati. Thank you very much. I'm happy to take any question.
After that great talk on fetoscopic surgeries, next we have Professor Dr. B.S. Ramamurthy, a consultant radiologist and fetal medicine specialist at Srinivasa Ultrasound Scanning Center, Bangalore.
Any one question? Jose is right now online. Any one or a couple of questions if someone wants to ask very specific questions for him. Thank you, Jose, for fantastic lecture, and we were all mesmerized for your technique, and we will hope we will have some collaborations. You being a mentor to the things, and medal upon एक medal. So we are going to honor you with what we call as a memento or a medal, and that's what we will have, and we will make sure that you get that medal from the Fetal Brain Society. we respect you, and this is for you. And mark of respect, this symbolizes India. Okay, and this is what we call Ashok Star, and it symbolizes the pride of India. And this, I will make sure that you thank you very much for joining.
Thank you very much.
You have got one question here, please.
Professor Joe's very interesting lecture. Do any of these children require post-natal correction or corrective surgery after antenatal repair?
Yes, so only about 10 cases have some signs on the MRI of tethering, but not clinically. Only 2 cases were worsening in the imaging. Again, not clinically impairment, but decided the neurosurgeon to do a resection of an inclusion cyst and tethering cord. But that is in 80 cases, so there was like 2% of the 2 or 3% of the cases only. So it's much less than usually in the open fetal surgery or in the postnatal surgery with experience we have before.
Please.
Thank you, sir, for the nice lecture. I wanted to ask about one of my cases of Sherry 2 malformation, in which there was a spinal kyphosis also. So are you doing like in the thoracolumbar region? Of course, the patient went for abortion, but are you doing such cases where the alignment is also different, along with the small gap, if the alignment is different? So what is the prognosis in such, if you're doing?
Yeah, one of the exclusion criteria in the MOMS trial is the kyphosis more than 30% degrees. So we are trying not to operate by prenatal surgery, these kind of cases with a very large defect and important kyphosis. We are more elastic right now with increasing our skills, even by stethoscopy. So we go until 40, 45 degrees mostly, but not more than that, because we are trying to be fit to the MOMS trial criteria, but I recognize that we are like just moving forward and being more elastic in different of the criteria.
Thank you very much, Prof. And thank you for joining us live. And it's
My
an honor
pleasure.
to have you here. Thank you very much. Now
Thank you. My
over to
pleasure.
our next faculty. We can start, Dr. Ramamurthy, please.
Yep. A very good morning. And it's a lovely event. Thank you, Prashant, for having conceived this and put us all together. I wish the nascent Brain World Association all success. It deserves that because we know how complicated the brain is, and we know how we can look at it right from the very origin in the first trimester up to the third trimester. Now, after 2 very exciting lectures about surgery, we come down to ultrasound, pattern recognition, and we come down to neural tube defects, but not the commoner open neural tube defects. It's the rarer closed neural defects or closed spinal dysraphism that we're going to deal with in this presentation. And I'm going to dedicate this to the living legend, Dr. Gustavo. A big hand to Dr. Gustavo. Now, what is closed spinal dysraphism? Refers to a range of skin-covered anomalies. Open, no skin cover; closed, skin cover. But what's common is open and closed is that there's an underlying neural tube anomaly, right? These defects are present in the low lumbar and sacral regions, and it's best that we look at embryology to understand. So I'm going to be very brief with embryology, just enough to know why it is a spectrum and not a single lesion. So you have lesions related to gastrulation, primary neurulation, only the neural tube disjunction aspect and not the neural tube closure. And of course, secondary neurulation, About 50 to 80% of cases, you have cutaneous markers, and that is how the postnatal detection is facilitated. Now, how do you classify general spinal dystrophism? Is open and closed, as we discussed a little while ago. And of course, because there's no skin cover in open, CSF leak is present, Chiari-2 malformation is present, and it is by far the commonest variety of spinal dystrophism. On the other hand, because of the skin covering the defect, there is no CSF leak, and no CSF leak means there's no Chiari-2 malformation, and this is rarer in the group. However, the detection rates are low. Why do we fail to detect closed spina bifida? One, we do not have the intracranial clue. Two, the lesion can be very subtle, and I'll take you through some of those lesions. And three, we miss it often because it is subtle and because the local sign which catches your eye is a cystic lesion at the level of the dystrophism. But if there's no cystic lesion, it becomes subtle, and that is why we miss it again. What are the other differences between open and closed? So you have the second hit neural damage by the amniotic fluid in open, but there's no second hit neural damage in the closed variety. The open variety is multifactorial. This is more genetic. Your AFP and acetylcholinesterase is elevated in open, but normal in closed. And that is why biochemical screen is ineffective. Again, another reason why your detection rates are low. Folic acid dependent, folic acid independent, commoner, rarer, and it's not associated with open neural tube defect is not associated with anomalies of kidney, bladder, gut, genitalia, etc. Whereas the closed ones are associated with the anomalies of the systems that we just recounted. Now, what are the essentials of diagnosis? First of all, normal intracranium in terms of the PCF. Secondly, the skin cover, continuity of the skin and the subcutaneous layer over the lesion. Description of the lesion is extremely important because that is where the surgeon gets to know more about the lesion in terms of a meningocele, in terms of a meningomyelocele, or in terms of a lipoma. Lesion level is important, and lesion level is the first segment of the involved length of the spine. The first segment, right? Tethered cord we should look for, and tethered cord in the second trimester is conus beyond the inferior border of L3. Cutaneous lesions we can see in terms of a pseudotail, and neuromuscular sequelae should be sought after. Now, we all know that in open neural tube defect, the various levels give rise to the various impairments of motor activity, but we do not know if this would translate to a closed spina bifida compared to an open spina bifida. A couple of hints or tips we need to know. So the skin covering is important to be seen in every case that we deal with in the mid-trimester anomaly scan. And to look at the skin, we need to have a sliver of amniotic fluid going across the dorsum. If there is no amniotic fluid, you wouldn't see this reflection. If the uterine wall and the dorsum is touching each other, you will never be able to trace the skin continuity. That's important. And number two, always a sagittal section to show that the sacral taper is present, and also the sacral taper is uplifted or up-tilted because of the lumbosacral promontory, which is there. And then, of course, we also should know how to actually look for the conus. Use of high frequency is extremely important. You will see that the conus, that's the spinal cord. You will see the central canal of the spinal cord, and you see the tapering, and that's the conus, beyond which is those fibrillar structures for all cauda equina that you can see. And once you see the conus, you can count the conus level either from below S4, from S4 upwards, or T12 downwards. And here you know that this is 4, 3, 2, 1, L4, L5, L4, L3. So it is not beyond the L3. It is tucked away above. So this is normal. This is normal. Also remember that the cord is hugging always the ventral aspect of the canal so that there is more CSF on the dorsal aspect. So these are the small things that we need to bear in mind. Right, so you can use multiplanar. You can use multiplanar imaging, and I have used VCI, a thick slice, VCI, a thick slice. You can put your dot in the known plane, and you can, on the coronal, you can count from your 12th rib downwards, a very, very easy technique to do. Right, now we go on to embryology, and when you talk of embryology, again, as I said before, gastrulation, 14 to 21 days, that is where the 2-layered embryo becomes a 3-layered embryo, and there is what is known as the neuroenteric canal. And if the neuroenteric canal is present, it's actually a very transient structure. It comes and then it disappears. But if it persists, you get your neuroenteric cysts, you get split cord anomalies or split notochord anomalies, and we'll look at that in a short while. So that is the canal which connects the ectodermal aspect, the amniotic cavity, to the yolk sac cavity. It's a tract which is very transient, but if it persists, it splits the nuchal cord, and you have a sinus-like communication between the yolk sac and the vertebral canal. Now, the yolk sac, this is the endometrium, the endoderm. Endoderm gives rise to gut, and this is the spinal canal. So ultimately, what happens is you have endoderm-lined cysts in the posterior mediastinum communicating with the central canal of the cord, and that is the essence of a neuroenteric cyst. And to go fast, you will see that in the 4-chamber view, you have the aorta over here highlighted in color, and behind the aorta, in front of the thoracic vertebra, you have a lot of cystic spaces there. So that is a posterior mediastinum cyst. When you do your longitudinal section, the aorta is moved up, is displaced anteriorly, and it's retroaortic. But what's interesting to us is at the level of the cyst, you find those vertebral anomalies. You have a classical hemivertebra here, you have a block vertebra there, and a posterior mediastinal cyst, which is pre-spinal with spinal or vertebral anomalies, means a neuroenteric cyst. And these are the MRI images. You see the cystic lesion there. That's the cystic lesion. Again, this is the intradural component of the cyst. You also find that the spinal canal is expanded here, and therefore this is a neuroenteric cyst. Again, another neuroenteric cyst here. You have a posterior cyst there. That is a hemivertebra, and these are this is the vertebral anomalies. That is the X-ray showing you the vertebral anomalies. And of course, on the transverse section, you find that there are 2 cords there. So this is diplomylia, 2 cords out here. And in this particular case, there was no tethered cord. Moving on to diastematomylia, this is the other lesion which is under the category of split notochord abnormalities. And we all know that this is a lesion where a central spinal or vertebral canal spur, which is cartilaginous or osseous or fibrous, splits the canal into 2, and therefore you have 2 types where 2 independent dural sacs or 1, that's type 1. Type 2 is 2 cords but enclosed in 1 single dura with 2 arachnoids, right? So here is the displaying of the posterior ossific centers. That is the spur that you can see, which is osseous on the coronal section. This is on the transverse section, and that's displaying there. And when you see carefully what's happening here within the canal, what do you see here? two cords, that's diplomylia, and this is L1, as you can count from below. And again, note that the skin continuity is maintained. The skin continuity is maintained, and you can do your 2Ds, 3Ds, so on and so forth. You can see the two. Can you see the two spinal cords there sitting next to each other on the coronal section? That's the spine, and that's the sagittal section. And you can do your 3D rendering again, showing the two cords very nicely. Here's another one, show another diastematomylia, and that's the spur that you can see in this rotational display that you have. And this is the low cord, the cord which has come down almost to L4, L5, and that's the third cord that you can see. So then we move on to the problem of primary neurulation. Primary neurulation is actually two-staged. The first stage is where the neural tube closes, and if it fails to close, the neural groove actually should close to form a neural tube. If that fails, you have what? Open spina bifida. But if that is successful, but the separation of the surface ectoderm from the neuroectoderm does not occur, that's called disjunction, right? Why should it occur? It should occur because the mesoderm should enter between the surface ectoderm and the neuroectoderm. If it doesn't, if the mesoderm doesn't come in, these two layers are stuck, the surface and the neuroectoderm, and because of that, you have dermal sinus, limited dorsal myeloschisis, and the lipoma group of disorders, and we'll move straight away to those disorders. And first, let us look at disorders of incomplete disjunction. So whenever there's a contact or an adherence between the neuroectoderm and the surface ectoderm, the neurocutaneous junction can be actually pulled up towards the skin this manner, and that gives rise to a limited dorsal myeloschisis. But if the junction moves towards the neural tube, it actually drags the what? The skin, and what is formed is a dermal sinus. If you understand the pathology, you will know what to look for. And let's look at this 24-weeker, and that's a clip. Very easy to diagnose because there's a mass lesion here. This mass is largely echogenic, and therefore it is fat, a lipoma. But I draw your attention to a hypoechoic snaking structure within. That is a sinus. And when I look at the transverse, I can trace the sinus to the surface of the skin there. That's the sinus on one side. And on the other side, the sinus is communicating with the neural tube. You can see the spinal cord there. That's the central canal. This is the lipoma. The lipoma is not only subcutaneous, but it's actually extending into the spinal canal, so much so that the spinal cord, the conus, is getting into the lipoma. And looking at the cord, lipoma junction is important from surgery point of view. These are the details which, if you offer, will actually supplant what an MR can do. You can do much better because your probes are high frequency, spectacular pictures, right? Now, this is one lesion which is a neonatal emergency because it's a communication from the skin into the neural tube, and that makes the fetus prone to meningitis. And this is where we need to look at it on a war footing. That's the cord lipoma interface. And of course, here is the pseudotail. So that's the pseudotail that you can see here. That's the pit where the dermal sinuses are opening. That's the pseudotail. And needless to say, there are no intracranial signs, right? And then we move on to limited dorsal myeloschisis, where the neurocutaneous junction goes up towards the skin. It drags the neural tube element or the neural element, and that is called a fibroneural stalk. Now, this is an easy lesion to pick up because there's a cystic lesion on the dorsum. But if you look carefully, it tapers off, peters off, and it goes to a small tract there and that's the tract. That's the tract that you can see, and you can see the same tract in the sagittal section. That tract contains a fibroneural stalk, and if the surgeon doesn't remove the fibroneural tract, then this is going to be the detethering will be unsuccessful. There is going to be a retethering. So therefore, we must be sensitive and let the surgeon know that, yes, this is the pathway of the tract. And again, the fact that what am I trying to show you here? The skin is easier to see, or the subcutaneous fat is easier to see? Fat is easier to see. Subcutaneous fat is a surrogate marker of skin. So don't go looking for the epidermis. To go for the subcutaneous layer, and you will see that the subcutaneous fat layer is reflected onto the lesion, telling you that it's a closed or an open lesion. Closed lesion, and needless to say, your posterior fossa is normal. Posterior fossa is normal. So that's a classical limited dorsal myeloschisis saccular variety. You can have flat varieties without a sac as well, right? So this is the value of looking at the angle between the dorsum and the surface of the lesion. If there is a taper that you can see here, that is closed. But if it's open without the skin cover, you don't get that tapered look, right? And of course, only in terminal myelocystocele was there a Chiari malformation. In all the other kinds of lesions in this paper, the posterior fossa was normal. So there are lesions in the closed spinal dystrophism, which may be associated with Chiari. Then we go to premature non-disjunction. Prashant, I've asked you permission for about, shall I finish? I'll finish fast. Okay, disjunction premature. Now, this is interesting to know. We know that the skin on the either side should connect, right, to form the surface ectoderm connects to form the skin. But if the disjunction, the mesoderm invading between the neural tube and the skin occurs before the neural tube closes, then what happens? The mesoderm or the mesenchyme has access to enter because it's still open. The skin is closed, the neural tube is open, so the mesoderm can get into the neural tube. And when the mesoderm gets into the neural tube, that forms a lipoma, and a classical lipoma has subcutaneous component going through the defect in the posterior arch, and it might extend into the spinal canal. So that is why premature disjunction is associated with the fatty components of, in terms of a simple lipoma, lipoma with meningocele, lipoma with meningocele. Now here is an example. This is a high frequency study, and you will see how elegantly you can look at these structures here. So here is the spinal cord. Instead of going along the ventral aspect, has been lifted off, and then it goes and gets itself adherent to this lesion, which is cystic and which is seen on the dorsum. Then the cord actually bends down and comes here, right? So that is and when you do a transverse section, you find that the neural cord is elevated. You see the nerve roots here. And what is the echogenicity here? Hyper. That's the lipo component. That's the lipo component. That's the lipo component. And this is the cord lipoma interface that you have here. And needless to say, what is continuous all over? Skin is beautifully seen continuous. So this is a closed neural tube defect, a myelocele with a very, very low cord. Cord is coming up to S3 that you can see here. That's the sacral taper. Now here is a tricky one. These are the ones which we have to be actually at the edge of our seats. Now here is a transverse section, and here you find splaying of the posterior ossific centers. Yes or no? Agreed? Your eyes will pick it up when you do a transfer sweep. And also the posterior centers are kind of scalloped. You can see the C shape that catches your eye. But what you have to also recognize is the lipoma. You can see that echogenic stuff there, right? Now, when you do a detailed scan, you go orthogonal and you're going to look for the conus. The conus comes down up to here, and that is L5. L5, that is S4, and certainly tethered cord. We don't look at the cord as a routine in a mid-trimester anomaly scan. Yes or no? No, we don't, right? But at the drop of a hat, we must look for it when you have subtle signs like this and look at the skin. It is continuous around a classical, simple myeloma, but with a tethered cord. With a tethered cord that you can see here, that's the conus medullaris. A good chance that one may miss it, and this is the tethered cord. The L3 is the cutoff inferior border in the mid-trimester anomaly scan, and this is from Koopman's article who described the femur, conus distance. Now we move on to the last aspect, which is secondary neurulation. Secondary neurulation is very interesting because most of the spinal cord comes from primary neurulation. But beyond S2 level, that is the terminal portion of the spinal cord, and the conus, the phylum, and the cauda equina, all of them come from secondary neurulation. Now, secondary neurulation starts off as a caudal eminence, which canalizes and joins the primary, giving rise to the complete spinal cord. And if you have problems with secondary neurulation, you have sacral agenesis, thick phylum, sacral limited dorsal myeloschisis, complex lipomas, myelocystoceles. Quickly, we'll go through. I'm not going to give you the text slides, but here is what you see here at 17 weeks. The spine appears truncated. And when I look at the iliac bones on either side are, there is what should have been there between. Sacrum is not there. So that's shield-like iliac bone. And you look at the intracranium, normal. There is a rocker-bottom foot that you can see here. And when you do your rendering, it's very easy to count because you know T12. That's T12. T12. And what is this? What is this? L? And beyond L1? So this is lumbosacral agenesis with neuromuscular, and you know that the skin is continuous, and that's failure of secondary neurulation. Failure of secondary neurulation, and you can see the details over here. So that's the truncated, that's another case showing you talipus, so on and so forth. That's you can pick these up in the first trimester. Here's a 12-week fetus, and transvaginal scan shows you an abrupt ending. You don't have kidneys over here. There's no bladder filling there. There's a radial ray defect here. 3D tells me that it is a partial sacral agenesis. Distal to S3 is missing. So you have a renal problem. You have an arm problem in terms of radial ray defect, and you have a spine problem. Does it strike a chord? Factor association, right? Then we move on to a simple lipoma. That's, to cut a long story short, a lipoma there. That's the cord coming in there and touching the lipoma. Again, cord lipoma interface. Those are the, this is important, a subtle, very subtle cystic lesion here at the tip of the sacrum. That's a terminal myelocystocele. Note that the skin is continuous. There is no changes in the posterior fossa. And lastly, the phylum terminal cyst. Now here is a lesion which you can easily miss, but if your eyes are sharp, when you do your transfer sweeps, you find that there's a small cystic lesion that you can see here at the tip of the phylum. The phylum itself is fairly thick. You can see the thick phylum there. That's the cyst that you have here. And of course, the fact that the cyst is at the S3, S4 level, and the conus is at L4, which tells you that yes, there is a tethered cord and the intracranium is normal. Caudal regression syndrome is associated with maternal GDM. We have enough data. This is one such case in a diabetic. The other way of classifying closed spinal dysraphisms is with subcutaneous mass, without subcutaneous mass, and certainly this group without subcutaneous mass is going to be the tougher challenge. Why is it important to distinguish closed from open? There is no neural placard damage by amniotic fluid. Chiari-2 is rare and hence no intracranial complications. Prognostication, motor impairment, and neurogenic bladder. Surgical plan depends on the pathologic anatomy, very important. No role for in utero surgery. More incidence of anal atresia, urinary tract, and skeletal anomalies. Role of invasive testing, especially chromosomal microarray, DNA storage, especially if it's a part of polymalformation. No role for folic acid prophylaxis. What are the principles of surgery? Understanding pathological anatomy, untether the cord, check the filum terminal, usage of intraoperative neuromonitoring to know what is going to be the defects or neuro deficiencies, closer to avoid CSF leak, right? So my last slide, knowing that intracranial signs are not forthcoming, knowing that closed lesions are subtle, and knowing that biochemical screening is ineffective, how can we increase the detection rates? You can increase the detection rates by first of all recognizing skin continuity over the spine. Be sensitive to subtle splaying of the posterior ossific centers. Look for soft tissue swelling. Recognize abnormal echogenic areas as potential lipomatous lesions. Always document the PCF, which of course all of us do. Be cognizant of the varied spectrum of closed spina bifida, and it's best understood on an embryological basis. We know it is associated with neurological dysfunction. Look for associated anomalies, invasive testing, recognition, early referral, and counseling by pediatric neurosurgeon. Thank you. Jai Hind.
Thank you, sir, for this amazing talk. Next, I would like to welcome Dr. Hriday Acharya, orthopedic spine surgeon from Ahmedabad. He specializes as pediatric spine surgeon, dealing with correction of congenital and acquired spinal deformities at younger age. He has special interest in pediatric and fetal spine-related pathology. Currently, he is the educational committee member at the Scoliosis Research Society, USA, and he has already published more than 10 papers on spinal deformities and related problems. So we're going to have a spine surgeon's view on spinal defect and its prognosis.
A very good morning, everyone. So we have been discussing about the open and the closed spinal dysraphisms, and this is one of the very common USG findings that you'll be seeing in your scans. And we in our OPDs, this is what we commonly look at, the patient's X-rays. And from going to the scans to the X-rays or to becoming older, the patient has so many questions like, will the baby have a straight spine? Will they need surgeries? Will they need one surgery, two surgeries? How many surgeries? Will there be a normal movement of the limbs that's going on? Will there be any associated complaints? So on and so forth. So here I'll be discussing about the spinal defects and the prognostication, and to say that connecting the missing link. So making the path simpler from the intrauterine phase to the adult phase so that we can actually stop the anomaly when the defect is really small. Instead of the patient having such a big kyphosis, we can stop it at this level. So to begin with, the evaluation of the spine anomalies. Generally after conception, there is formation of the spine anomalies which occur at the 6th week. We have been discussing the second hit phenomenon throughout this session, which means that after the formation of the anomalies, the open defect comes in contact with the amniotic fluid, which causes the worsening of the defects. After the defect, the child is born. They have presentation of the symptoms. If there is a mild kyphosis, scoliosis, they generally present later in their age. Or tethered cord generally presents after they develop some complaints for which they are investigated. And this is when actually the spine surgeon comes into play. Here we know that now we can diagnose anomalies pretty early. And at an early stage, we can have the fetal medicine consultant join in with the spine surgeon and thereby starting the fetal surgery as we discussed, preventing the second hit phenomenon. Also, if the fetal surgery are not possible, probably immediately after the birth, the fetal medicine consultant, the obstetrician and the spine surgeon can team up, thereby planning early management. This is what we get the lead time both in managing and diagnosing the fetal spine anomalies. This lead time will help in timely discontinuation of the pregnancy if the child's disabilities are very severe. Also, a combined decision with the parents can be planned to continue the pregnancy after knowing about the potential disabilities that the child will have. Predicting the problem and treatment plan early, that would help us start the treatment as soon as birth, like closing the meningomyelocele at birth, or maybe starting the treatment for the hemivertebras. And the spine surgeon involvement will help in optimal treatment planning. So we have come with an algorithm for such kind of patients. The algorithm is divided into 4 main parts. The first being diagnosis, the counseling, the management before birth, which is the intrauterine management, and the management after birth. So the diagnosis, which is done by the fetal medicine expert, which would help in identifying which cluster of the patients comes into the algorithm. The counseling, which is done by the team of the fetal medicine expert, the obstetrician and the spine surgeon, which is the entry point of the surgeon, the pediatric, the spine surgeon into the algorithm. Management before birth, which is again done by the entire team, which we have been discussed about, which is the earliest possible interventional role. And the last is management after birth, which is the handing over of the patients to the surgeon. This is the point which is the missed point, and an early diagnosis and early planning, early involvement of the surgeon will help in continuing the algorithm. So from a fetal medicine perspective, you all are expert at diagnosis and you don't need any of these. The counseling would include critical pointers which will help us as surgeons to counsel the patient better. The management before birth, which is possible in a few select cases, and management after birth, which has to be individualized and can be started as early as possible. So we classified them into 4 basic parts. The first being open neural tube defects like the meningomyelocele, the closed benign cord anomalies like the split cord and the tether cords, the congenital bony anomalies like hemivertebras, and the fetal kyphosis and scoliosis, where there were no apparent abnormality, but there was just a change in the curvature. So let's begin with the open neural tube defects. So the diagnosis is generally in the late first trimester, and all of this has been discussed about, and such patients may need an MRI. We need to counsel the patients based on the region. So the region of the defect is to be known. The size of the defect is what we would generally expect in the USG finding. So higher the defect, better is the prognosis. Smaller the defect, better is the prognosis. And a worse USG finding with brain involvement, as you all know, will have worse prognosis. Management before birth, I won't discuss because it has been discussed really well. And management after birth, with early knowing closure within the first 24 hours, will help in better prognosis of such patients. So this is the patient. The same patient was operated in the first 24 hours, and we see this normal child moving around. So intrauterine MMC closures is what we have already been discussed. The second are closed benign cord anomalies like the tether and the split cord. So what do you see? They are generally diagnosed in the second trimester. We need to know the level of the chorda equina. Also the part, is this the bony or the ligamentous spur that is actually causing the split. The counseling is based again on the region. Higher is the better. Prognosis is generally favorable, and we should counsel regarding the need of a surgery to release the split cord. Management before birth is not yet known. After birth, again, such patients will need close follow-ups. Any early neurological sequelae development will need an early MRI and to be operated as soon as possible. So just an example here, we see a split cord malformation with a bony spur, which is causing the splitting of the cord. As the cord comes down, it splits into 2 halves. Generally, if the halves are same, generally does not cause any problem. But a lot of times, one of the images that Dr. Ramamurthy showed had one cord which was smaller and the other cord which was larger, which splits like that. So on an MRI of an adult, the child is born, this is what it looks like in the normal split cord, and this is what it will look if one cord is shorter and the other is longer. So we see 2 similar eyes coming in a equally divided chord and a winking eye sign when we see if the one chord is smaller and the other is shorter. In case if the chords are not same, one of the limb will develop short, the other will develop long, causing a limb length discrepancy. So whenever you do a scan, in case if it's possible to know that if the two halves are equal or not, it will actually help in prognosticating how it will be. Similarly, this kid has one foot that's smaller and the other foot that's longer. Another thing that so this is the same split cord syndrome, and intraoperatively, this is what you see. There are the two cords here. One of the cord is smaller, other is bigger, and that's a bony spur that had to be released. So the second important thing that you commonly see in your scans is the tether cord. Generally, those patients are normal, but they do need a release. Most common presentations are back pain, neurological deficits, and scoliosis. But why does that happen? So this is the tether that's holding the cord from below. As the child grows, the cord keeps on growing, but there's a constant tug that pulls the cord down, causing the scoliosis to happen. So instead of it being a straight cord, it becomes a curved cord because there's a constant tug or pull that's coming downstairs, and that's what presents as a scoliosis. This is a patient who had just a tether cord and initially was all normal, but as the baby grew, she developed a scoliosis. The next in line are congenital bony anomalies. So again, they can be diagnosed in the late first and second trimester. They can be either hemivertebras, block vertebras, associated rib anomalies. What is important to look at is the anatomical location. Is it cervical, thoracic, or lumbar? Is it an anterior, posterior, or a lateral? And the number of anomalous bodies that can be found. The counseling is based on the region where it is, the number of bodies involved, and the location. These patients have to be counseled regarding a possible need of a surgery, and as we have been discussed about a syndromic association, if it's not found in the USG. Management before birth is not yet done, and after birth, all of them need close observation, screening for any associated syndromes, and early MRI whenever possible, and we can plan for management based on serial radiographs. So this is one of the most common defects that you see in your scans, and similarly, this is how commonly we see in our OPDs as well. So this is a hemivertebra, and hemivertebras behave really unpredictably. This kid also has a hemivertebra, and so does this. So what we need to define is that in which prototype does our patient belong, number one, and number two, does the patient progress from being so normal to having such a kyphotic back? So this will be defined by three major things. The first being area. Is it cervical, thoracic, or the lumbar? The thoracic spine has the ribs, and ribs are something that hold on to the vertebra really well. So the ribs, the vertebra just doesn't go haywire. The lumbar and the cervical spine are really mobile spine, and a defect in the cervical and the lumbar will have a worse prognosis. The second are the number. Is it 1, 2, or many? Generally, 2 or more hemivertebras have a worse prognosis. If it's 2 hemivertebras located at 2 different levels, one being right, one being left, then they will eventually balance each other. We might have a straight spine in a multi-level hemivertebra. The last being location. Is it anterior, posterior, or lateral? So an anterior hemivertebra, as we know, will cause kyphosis. Kyphosis generally causes the stretching of the cord and causing neurological deficits. So anterior hemivertebra is actually worse when neurological point of view is concerned. Whereas a lateral hemivertebra will develop a worse scoliosis because there is something extra on the lateral side causing curve on the other side. So this is one hemivertebra which presents as a simple young baby who doesn't have anything, and such patients can be managed just conservatively, not doing anything at all. On the other hand, if somebody like this is a 13-year-old boy with hemivertebra, as we saw, it is a single level dorsal level located anteriorly. So we see significant kyphosis here. Since it was an single hemal dorsal vertebra, they presented the patient at 13 years, which is pretty old. So this is the presentation. Of course, we operated on this patient and corrected the spine, and this is what we made him. So this is both of them are the same patients, and of course, this is possible in almost all hemivertebra patients. The last but not the least are fetal kyphosis and fetal scoliosis. So they are the most tricky ones. They can be again be diagnosed in the late first and second trimester, but the only change is the change in the contour of the spine, and we could not find any associated bony anomalies. So such patients would need an MRI to rule out anything if there is something that we miss out. A very high degree of suspicion is needed. Such patients may or may not need surgeries, and they might be associated with syndromes. So management after birth needs very close follow-up to be investigated for anything that associated. We need an early MRI and can start treatment as early as possible. So to give an example, this is one baby with a mild kyphosis that you would see on a USG. Now, when we saw the baby, because of the kyphosis, there was significant nerve compression and the patient was not able to move her limbs. Initially, when the baby was a 2-year-old kid, she was walking very fine, and she presented to us at 3.5 years, and she was not walking since the last 6 months. She also had an associated upper limb abnormality, and as we see, it was a Marquis syndrome. Now, if you see a mild kyphosis, a mild scoliosis, then we might ask for genetic testing, screening in subsequent pregnancies, and counseling regarding any other spinal anomalies if there are any. This is another patient with just a scoliosis without any specific bony or intracanal abnormalities. So we should be highly suspicious about a mild kyphosis or a mild scoliosis when you see those on your ultrasound images. So there are a few notes of caution. The first is that, of course, with MRIs, we could predict some neurology, but the future, that how will the baby behave neurologically, could not be predicted. The second most important are the bowel and bladder functions. So bowel and bladder functions, which we generally do not discuss, but they become a very important part when the baby grows up. And those could not be predicted because it is a myelination thing. If there are something in the sacral region that is not developed, then they might have an incontinence in the bowel and the bladder. A few syndromes can be missed on an ultrasound. And since it's an ultrasound-based algorithm, a fetal MRI would help us improve the accuracy of the algorithm. So to conclude, fetal spine anomalies, once diagnosed, the spine surgeon and the team can counseling the patients regarding the possible disabilities. The patient can either plan to discontinue the pregnancy. In case they plan to discontinue, a fetogram, genetic testing, external photographs, and a fetal MRI can be suggested, and they can be counseled regarding the subsequent pregnancies. If they plan to continue the pregnancy, we need to rule out any genetic syndromes that are associated with them. And intrauterine management, if possible, that can be done in select patients. If they cannot be done, all of them need to be followed till birth. And early operative management should be done in selected patients. Screen for any missed defects or syndromes, and a close follow-up so that whenever the kid is younger, we could operate them early and prevent worse defects. Thank you.
Well,
Any questions?
yes,
Please.
really enjoyed your talk and the counseling bit with it. I just wanted to find out, because my thoughts are that if it's non-syndromic hemivertebrates, we say you all can treat really well. So is that a right thinking, or are there some hemivertebrates that you may say that?
So generally, a single hemivertebra or two hemivertebras have a very good prognosis. What generally depends is the location, as I discussed. Multiple hemivertebras would have a worse prognosis because in one of the examples that you see, we generally remove the extra hemivertebra which is there, correcting the spine. If there are multiple hemivertebras, removing multiple hemivertebras is generally not possible. So what generally patients to ask us is that, will the kid have a very straight spine as you and me? Is generally what the patients come to us. So a single hemivertebra can have less defect, maybe only 10 to 20% worse than a normal spine, which is generally not seen clothed. Versus a multi-level hemivertebra will generally have a more severe defect, and correcting them are equally difficult.
So the example you showed, what did that have?
For the single level hemivertebra, D10 level. And it was an anterior hemivertebra, so that's why it caused the kyphosis. And lateral, which caused the scoliosis.
In most spinal defects, open or closed neural tube defects, we can always expect tethering, right?
Yes, in a lot of them we can
Because,
expect.
we spend a lot of time in locating the tethering,
Yes.
etc. It's always expected. We
Yes.
don't really need to look for it.
But there are isolated tethers that also come in. So when there are multiple spinal defects, the counseling becomes simpler because in India, at least, when there are multiple pregnancies, patients are more towards not continuing a pregnancy. What's an isolated tether is what I was talking about. If it's an isolated tether, such patients may also need surgeries because just an isolated tether can be a cause of scoliosis.
Thank you, Hriday.
Thank you.
It was a nice session. Thank you very much for your all possible options. We have a very short session for inaugural ceremony. May I invite the Gustavo Malinger, Professor Gustavo Malinger, Professor Dario Palladini. Can I invite Dr. Utsiko Poo, Professor Daniela? Is she here, Dr. Daniela Pryor? Yeah, madam, she is here. And of course, I'll join them. Then before Dr. Gustavo starts telling something, we will, as a tradition, we will go for the lightening of lamp, and then we proceed for the things. It's okay, it's fine. Is a first official constitution of the board, which is being done right now. And because any society, if it has to function, it has to have a board, then the board members, and then the members, and then we carry out further. So this is the first step for official society formation. And these five who are standing on the stage are the first five board members here, and to Karina Heratz and Rui Barbam. So we have 7 board members right now, and then that's the primary functional body, and then it will go on doing next stage. So first, here
I have only a few words. May I have the slide? There is only there are four slides, but they are more or less the same. So we have everything there. Okay, not needed. It's okay, not needed, not needed. I never read. Always I do that without preparing. But today I need to read because I am quite a lot of emotions to be here. So good morning and welcome to the inaugural session of the first Congress. It's okay then. Only there. Okay. So welcome to the Congress and to the recently created Fetal Brain Society. And I can tell you, you are the founder members of our society. So good for every one of us. And this will be the logo of our society. You can see it everywhere. I want to thank the organizing committee and in particular Dr. Prashant Acharya and his team for all the excellent work they have done. The initiative we create with the society was to bring people from all around the world and also from India to participate and to be speakers. And I am sure there are many other persons and people around the world that are very experienced with fetal neurosonography and the Fetal Brain Society and pediatric neurology, pediatric genetics, and also surgery that will be able to participate, that will be interested for the first time. These were our lectures. I also need to tell you that we are working on this issue for many years. This is the first page of the brochure we prepare for the planned Congress that was supposed to be held in Mumbai in 2020, but because of the organizational problems and also we were knowing that the corona is coming. We didn't do that in 2020, so it took another 4 years to be able to organize. This Congress is held thanks to the invaluable collaboration of General Electric and their local representatives. They have been for many years helping the advancement not only of OBGYN ultrasound, but also fetal neurology, and they understand the importance of fetal neurosonography, providing first-line equipment and facilitating research in this field. For those that were not there at the beginning, and I can see here many young colleagues, until no long ago, the fetal brain examination was limited to the presence of the cranium and the measurement of the lateral ventricles. In the late 80s, pioneers of prenatal diagnosis, such as Campbell in the UK, Enrico Pilo in Italia, Benacerraf, Romero, Hobbins, Phil in the United States, and Laroche, Drull in France, and also Professor Merz in Germany, published their experience with the diagnosis of some CNS anomalies. At the same time, experience was gained with the introduction of transfontanellal ultrasound by pediatric radiologists that eventually, whatever that you see, they were able to see in the newborn through the transfontanellal approach is what we are doing today in our fetuses. The biggest step, to my understanding, toward the complete visualization of the fetal brain was possibly following the development of the Elsint mechanical transvaginal transducer by Ilan Timor and Moshe Bronstein in Israel. Now, from my personal point of view, in '88, I started studying the fetal brain anatomy during the second and third trimester using this probe, and slowly I start finding some anomalies. But colleagues at home and abroad were not interested and my papers were rejected one after the other. And one of the important things when you work is not to go down, to continue trying. I felt that the big opportunity to present my investigations will be at the 2000 ISWA Congress that was held in Zagreb, Croatia. the abstract was accepted for communication. But I realized that it was accepted for a session that was called something like non-relevant, miscellaneous, and others. Those are the sessions that are, it's the last day of the Congress in the basement, where only the chair of the session, because the other chair didn't come, and only the participants, and perhaps if your wife is there, they participate. And it may make me crazy, because I was sure that what I willing to present was important. No one understands. I refused to give the lecture. I say, if you don't want to hear me, you are not going to hear me. At this time, the Zagreb airport was very small, and all of the Israelis were flying at the same time to Israel, and it was at the same time the Italians. And I think that Dario Palladini, I think you were there in the airport. I am not completely sure, but and we were there waiting for our planes, and Gianluigi Pilo came to me and said, perhaps you were willing to present the lecture that you didn't present in the Congress here for the Italian participants. So I present my lecture in the airport, sitting with a laptop. Everyone was after me, and actually this was the start of what we are doing here. So be perseverant. Don't let people downgrade you. And the rest is another history that perhaps I will be able to tell you in other meetings in the second Congress, that by now we don't know where we are going to do it. 23 years later, we are sitting here ready to hear developments, not only on the field of ultrasound, but also on MRI, genetics, pediatric neurology and neurosurgery, as well as on pathology. We understand that the field has become not only complicated, but dangerous, since development has raised the expectation to be able to deliver 100% correct diagnosis, knowing by ourselves that this is impossible. The true way to do as best as possible is without doubt by putting together the experience of all the mentioned fields, providing in every difficult case a multidisciplinary counseling based on the knowledge of all the participants. This is the main motivation of the creation of the Fetal Brain Society, and we invite you, as well as every interested colleagues, to join us in this effort. Enjoy the lectures and also the beautiful city of Ahmedabad. Thank you.
Thank you.
It's much more difficult to read than to speak.
May I request Dario, Dr. Professor Dario Palladini, to say a few words about the Congress.
Thank you, Prashant. First of all, congratulations for putting all this stuff together. It's been a major effort for you and your team, so sponsors as well. So, chapeau for what you put together, all these brains and new generations. Having said that, I think that Gustavo mentioned this, the very start of this entity, which is fetal brain science and ultrasound. I think a major role has been played by Ilan Frisch over the last 20 years, because it was one pioneer in a 3D assessment of the fetal brain. So I think he's looking at us from US now, and I think he inspired several of us and will inspire also several of the new generations. With this Congress, we try to put together all the different aspects, as Gustavo was mentioning, and we hope that putting a first day of more educational activities together with the more robust scientific and multidisciplinary part, which started today and will last until the last day with the courses, will be of inspiration for the young generation, and also a kind of continuous education for those of us who are not so young anymore, but may find additional motivation there in our everyday life and work. And so I wish everybody here in the audience all the best. Enjoy your time in Ahmedabad and your time here with us at the conference. And thank you again.
So last 20 seconds. Again, thank you from bottom of my heart to Gustavo, Professor Dario Palladini, Professor Daniela Pryor, and Dr. Rutsika Poo, Rui, and Karina. It's a brilliant effort, and it was, I think, we must have carried out more than 15 or 20 Zoom meetings discussing for a various length, various small little aspect of what topics. On one topic, I think we may have discussed for 15, 20 minutes. Yes, this is required, not required, who is going to speak, who is going to discuss. So there is a lot of efforts which are put in by all the stalwarts who are sitting here. And I will never forget my family and my team. Thank you, Ashini, for tolerating me for practically 3 months. You know, when I'm for the lifetime, of course. So she's tolerating me for the lifetime, so that's correct. I will change my this line. She has been amazing, supportive in all aspects of my life. Thank you, Ashini, for being in my life. But altogether, my both Hriday and Forum and their partners, Rini and Samak, they all has been fantastic. The team Orange Rose, those who have taken care of everyone nicely. Thank you, Rohan and the team, and of course, team GE. GE has supported not only sponsoring the event quite handsomely, but we are we got a good support from always for all academic aspect. Not mentioning, not forgetting the SNG Lab, accurate printers, Scan OFI, and of course the books stalls which we have from Oliver. So anyway, thank you very much and enjoy stay here for 4 days, and hope at the end. Hi Rui, are you there?
Hi friends, how are you?
Thank you very much, Rui, for joining live. Thank you very much.
I apologize for doing that from the car. I truly apologize, but I will see you later on in my talk, so I will be there live. All the best and greetings, and we miss you here, and we really wish we were able to be there with you, but we are absolutely with you in our minds and with our thoughts and with our passion to what we do.
Thank you. So we have a short break for coffee, exactly for 15 minutes, and we will start the session after 15 minutes. Thank you very much.